Good morning, esteemed faculty and colleagues. Welcome to day 2 of the TMC Postgraduate Teaching Program 2026. We hope day 1 was insightful. Today, we'll be covering discussions on salivary gland, larynx, and robotic surgery. Our first session would be a case presentation and discussion on mucoepidermoid carcinoma of the parotid gland. In our expert panel, we have Dr. Vidisha Tunjapurkar, who is a professor in the Department of Head Neck Surgical Oncology, Tata Memorial Hospital. Next, we have Dr. Saurav Arora, the Principal Director and Clinical Administrator, Department of Surgical Oncology, Max Super Specialty Hospitals in Delhi NCR. Then we have Dr. Kabiri Kakoti, who is a professor in the Department of Head Neck Surgical Oncology, Dr. B. Barua Cancer Institute, TMC, Guwahati. And then we have Dr. Madan Gupta, who is a senior consultant in the Department of Head Neck Surgical Oncology, Paras Hospital. Today's session will be moderated by Dr. Siddharth Basuroy, who is an assistant professor in the Department of Head Neck Surgical Oncology, Tata Memorial Center, Navi Mumbai. And this case presentation will be presented by Dr. Priyank Nandania, who is a third-year resident, Department of Surgical Oncology, ACTREC, Tata Memorial Center, Navi Mumbai. I would request Dr. Priyank Nandania now to please present the case. Good morning, everyone. My slide is visible, sir.
Yes, it is visible.
Shall I start?
Yeah, go ahead.
So I am presenting the case of 30-year female patient residing at Gorakhpur, Uttar Pradesh. A housewife came with the chief complaint of swelling below the left ear since 6 months. Patient was relatively asymptomatic before 6 months when she noticed the swelling in which was initially small in size and gradually progressive up to the present size. Swelling was not associated with the pain. There is no history of sudden increase in the size of the swelling, no history of halitosis, fever, or discharge from the oral cavity, no history of erythema over the skin, no history of pain or waxing, waning with meals, no history of other swelling on the face or anywhere else in the body, no history of dry eyes or dry mouth, no history of skin lesions over eyes, ear, or scalp. There is no history of decrease in mouth opening, no history of ear discharge or ear bleed, no history of ulceration or skin changes over the swelling, no history of difficulty in swallowing or voice change or regurgitation of fits or difficulty in turning of neck or difficulty in articulation. There is no history of asymmetry of face, difficulty in closing of eyes, deviation of angle of mouth, or drooling of saliva. There is no history of cough, bone pain, or weight loss. And there is no history of prior radiation exposure. Past history. There is no similar complaints in the past. Patient has not taken any prior treatment for the current complaints. No history of diabetes mellitus, hypertension, or tuberculosis. There is no history of prior surgeries or hospital admissions. Family history not significant. Patient is having no addiction of smoking, alcohol, tobacco. Diet is veg. Appetite is adequate. Sleep regular. Bowel bladder habits are unaltered. Patient has no non-drug allergies. So to summarize, my patient is 30-year-old female, housewife, nil comorbidities, no habits, presenting with a painless, gradually progressive swelling below the left ear since 6 months. Coming to the general examination, patient is conscious, cooperative, oriented to time, place, and person. well-built and nourished, echo performance status 0, vitally stable, no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy or pedal. On the local examination, there is a single, approximately 2 by 2 centimeter circumscribed globular swelling is present in the left intra-auricular region, superiorly approximately 1 centimeter below the tragus, inferiorly extending to the angle of mandible, anteriorly 1 centimeter away from the ear lobule, posteriorly 1 centimeter away from the ear lobule, obliterating the retromandibular groove. Surface is smooth and with well-defined borders. Overlying skin is normal, no erythematous, no ulceration is seen. Ear lobule is normal in position. There is no visible scar, sinus, or dilated veins over the neck. Palpation. Inspectory findings were confirmed on the palpation. There is 2 by 2 centimeter well circumscribed swelling is seen in the palpated in the left intra auricular region, which is firm in consistency, non-tender on palpation, mobile with no local rise of temperature, with overlying skin pinchable and not tethered. Uh, uh, Mouth opening is approximately 4 centimeter with Stenson duct opening normal, and the rest of the oral cavity examination is also normal. Facial nerve examination, there is a bilateral, there is facial symmetry present with no sign of facial deficit. Lower cranial nerve, there is no lower cranial nerve deficit. On the oropharynx examination, there is no bulge in the tonsillar fossa. Position of the uvula is central. Hopkins bilateral on Hopkins examination, bilateral mobile vocal cords are seen. There is no palpable cervical lymphadenopathy present. On the ear examination, bilateral tympanic membrane is intact. There is no pathology in ESC. Eyes, ear, scalp examination is also normal, and there is the systemic examination also normal.
Okay, Dr. Priyank,
Yes, sir.
can you explain us the various negative histories that you have asked?
Okay, sir. So I started with the association of pain with this swelling. So I have asked this history to rule out the infective or inflammatory etiology. Most of the in the condition like parotitis, bacterial sialadenitis, where patient can be present with the pain with the swelling, or when there is a rapidly progressive or when there is a malignancy, patient can also present with the pain. Uh, no history of sudden increase in the size of the swelling. Sometimes uh, a tumor like pleomorphic adenoma or Warthin's tumor, there is a hemorrhage in the inside the swelling, which can rapidly cause the increase of the size of the swelling. No history of halitosis, fever, or discharge. I have asked this history to rule out the infective cause. When there is a bacterial C. albinitis, there is a pus discharge. Pus discharge can be present from the Stenson duct, and patient can also present with the fever. And patient also can have a poor oral hygiene, uh, which can cause halitosis. No history of erythema over the skin. Shall I continue, sir?
Yes,
Okay.
yes.
Any questions from the examination
Priya,
from the history?
Yes, ma'am.
why? Yes, can I just say something?
Yes, ma'am.
You have assumed directly that it's a parotid swelling. Can you think of any other pathologies that can give rise to an intraauricular swelling? You have
Uh,
taken a whole history thinking that it's a parotid in mind,
yes,
but what other things that can come at this location?
it can be a intraparotid lymph node also, ma'am. And the inflammatory condition like sarcoidosis, autoimmune condition like Sjogren syndrome, or
Talk about no, commoner things before sarcoidosis and Sjogren's are very uncommon presentations for you. What other swellings can come at this high level 2 location?
uh, uh, level 2 lymph node can also be present at the intraauricular lesion, ma'am.
Okay, anything else? Can it be swellings arising from mandible? Can it be something arising from the parapharyngeal space?
Yes, ma'am. It can be a parapharyngeal swelling like schwannoma, paraganglioma, carotid body tumor can also be arise in the neck.
Have you thought about primary bony malignancies arising from mandible? There are a lot of other pathologies that can present to you at this location. So just don't jump to the conclusion that it's coming from parotid.
Okay, yes, ma'am.
Also, in your examination, have you talked about various scalp examinations, skin around the parotid? Have you talked about parapharyngeal space, intraoral tonsillar displacement?
Yes, ma'am.
So other pathologies you should think.
So
Priyank,
Priyank, can you go to the DD, your last part, differential diagnosis? So you have written as a parotid neoplasm. That is fine. What is the most probable neoplasm it is?
Sir, it could be a
Depending
benign.
on your history and
Yes, sir.
examination.
So my patient, the swelling is the present since 6 months, it is slowly, gradually progressive. So it can be a neoplastic etiology. It could be a benign neoplasm or like pleomorphic adenoma, or because of the consistency of the swelling. And there it could be a low-grade malignancy also, like mucoepidermal carcinoma, because these are also with slowly progressive swelling, sir, with indolent behavior.
Which is more common, pleomorphic adenoma or benign tumor, based
So
on
most
your
common is
history and examination?
the most common is the pleomorphic adenoma. 80% of the benign swelling are the parotids.
So that's very important. You should not jump from because you know beforehand what is the pathology and FNAC.
Yes,
So
sir.
you should not jump that it's in the same tone that it is a benign tumor like pleomorphic edema or low grade mucoepidermoid carcinoma or low grade malignancy of the parotid. You should stick to that it's looking like a benign tumor. Then
Yes,
the
sir.
examiner can ask the next question.
Yes, sir.
Priyank, as Dr. Vidisha had highlighted a number of differential diagnoses apart from the parotid here. So now, because you have already taken the history and the examination also, how will you rule out the other differential diagnosis and sort of zero it on only on parotid? How, from your history and clinical examination, you can do that?
Like only
So,
for
got your
clinical
mind?
exam.
I mean, Dr. Vidisha told it can be various other differential diagnoses, no? Apart from the parotid.
Yes,
Like
ma'am.
you
Yes.
told it can be a level 2 parotid. She told it can be a bony tumor. You told it can be a parapharyngeal tumor. So how will you now, because you have given a DD of parotids, so how will you now say that it is not the other differential diagnosis, but can be a parotid from your history and clinical examination?
So from the history lab, first my duration is up to 6 months. Like it is not a acute swelling like present within a week or a month, which can be an inflammatory origin or infective origin. Uh, with the other, and if it is a lymphoma, there is no other swelling present on the opposite side. So I can rule out it is not from the autoimmune condition like Sjogren or
As she shared,
sarcoidosis.
Jorgens is not a common differential diagnosis. Tell us about the other commoner differential diagnosis which you have ruled out from your history and examination.
So Priyank, why you think it is a parotid swelling is what everybody is asking. Can it be a mandibular swelling or any other site from where the swelling has originated? So how did your examination zero it down to a parotid swelling?
Because from your history, you cannot actually say the sort of either it's bony or it is from parapharynx. But now you have also done the clinical examination, no?
So
So now your differential diagnosis will zero it to some fewer diagnosis. So why is it parotid and not others?
So I tried to I have in the palpation I have examined tried to mobilize the swelling. Swelling is mobile. It is and it is not mobilized in the vertical direction. So parotid swelling Usually parotid are covered with the deep investing layer of the cervical fascia, so which restricts its mobility to toward the in vertical direction. But it can be, I can mobilize it in the horizontal direction. So I can say it is from the parotid.
So what have you ruled out from this?
So it is no it is not a swelling arising for, it is not an lymph node, ma'am.
So why did you
So
say that?
they have, so Priyank, they have asked you, DD, when they have questioned, Vidisha questioned you that it may be a bony swelling, it may be a parapharynx. You have told that schwannoma or maybe carotid body. How you differentiate from those to the parotid swelling, and your answer will come.
Uh, so bony swelling can be a hard swelling, and
Will that swelling be mobile if it's a bony swelling?
Yeah, yes, it will be.
no, so it will be hard and non-mobile swelling, sir. And on the if it is arising, it is a parapharyngeal swelling. On the oral examination, I'll be able to see a bulge in the tonsil or the oropharynx, sir.
And for the carotid body?
So there will be a pulsation over.
Yes.
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 Okay, so
And
you
from
have to
upper
differentiate
cervical?
like this.
Yes, sir.
Mm.
Hi, Priyank. Dr. Madan Gupta here.
Yes, sir. Good morning, sir.
Good morning. So, we have taken very well history. So, in history, you have mentioned there is no history of radiation exposure. Why did you take this history?
So certain tumors like Warthin's tumor and mucopolymeric carcinoma have association with the radiation history. Historically, low radiation was given to in view of tonsil lymphoma, thymus, and acne, sir. So to rule out that cause, I have asked about the radiation.
Okay. Any evidence to suggest your statement? Have you gone through any paper?
No such thing.
Okay.
And just to add to the discussion, Priyank, if it's a lymph node swelling, which was asked to you, if you contract the sternocleidomastoid, a parotid swelling will become more apparent. It's above the sternocleidomastoid, and the lymph node swelling will be less apparent. Okay,
Yes.
that is how you will distinguish it from an upper cervical lymph node.
Yes, sir.
So,
Okay,
okay,
go
this
ahead.
is
Yeah.
So I would like to first initial investigations. I would like to do a USG and guided FNSC.
why do you want to do FNSC?
So to confirm the diagnosis, which will affect my surgical plan and further treatment, sir.
How? It's a 2 centimeter small lesion. What will be your treatment plan?
So if it is a benign, my treatment plan will be a surgery. If it is a benign lesion,
If suppose it's a malignant lesion, what will be your plan? 2 centimeter, small, mobile, no lymph node.
so I will go with the surgery, sir.
What surgery?
So if it's a low grade tumor, then I will go with the if I can get enough
Don't
adequate
have
margin.
FNAC. You don't have FNAC yet is what he's asking. And what about
Yes.
imaging?
Yes,
What will you do first, imaging or FNAC?
first FNS is
First FNAC.
well, yeah, I will do USD guided FNSA, ma'am. For in this case.
So in USD, you will see the USD also, no? You'll just
Yes,
not
ma'am.
use
Yes,
it
ma'am.
for
Yes.
FNSA, right?
Yes, ma'am.
Okay, from the imaging point, what would be your first line imaging and what's the adequate imaging in this case?
It is as it is a 2 by 2 centimeter mobile swelling, and mostly it's a superficial. I will go with the
Hello?
yes.
Yeah, please go ahead.
So it is a mobile superficial swelling. That so in that case, USD would be sufficient for this case.
Which is the best imaging to differentiate between benign versus malignant?
So MRI of to differentiate between benign and malignant, investigation of choices MRIs.
Good, very good.
So what are the things you will see in the MRI?
So in the MRI, whether it is an intragranular or extragranular cystic component or is there or not, or status of the facial nerve, whether it is so whether the swelling is in the superficial lobe or deep lobe, if there is an extension in the deep lobe, and
Anything about lymph nodes?
yes, sir. If there is any positive nodes are involved or not, sir. If there is any positive node, are there or not?
So Priyank, you said USG guided FNSE. Why?
Sir,
Why not
because
without USG guided FNSE? Just you can palpate the swelling.
because sir, so we can target the exact representative part without USG. There are chances we will not get a adequate sample, or it can be only fluid also, sir. In case of the cystic
What is the representative part?
sir, other than cystic part, we can take the tissue, sir.
So are you looking for a solid component?
Yes, yes, sir.
Why? So why to FNAC, not to cut biopsy?
Sir, for to cut biopsies, so for FNSC, Smith analysis said that its sensitivity is 97 and specificity is 96% for the differentiate between from the neoplastic and non-neoplastic etiology. So
it is very different from the different studies. So it's around 90% sensitivity
yes.
specificity for the FNAC. So when you want to do not the FNAC and you will go ahead with the biopsy, to cut biopsy, in which
So
cases?
when there is a two non-diagnosis FNSC, in case of the lymphoma, when I need a IHC or molecular typing, or in the recurrent or redo cases, I will go for biopsy, sir.
Why in
So
recurrent and
basically,
redo cases? In the recurrent, why in the recurrent and redo cases? You have told.
Sir, to get the in FNSC, we are not able to get the proper architecture. If it is a recurrent cases, it can be a high grade tumor. So to get a proper grading,
Which recurrent cases you will do a biopsy and not the FNAC?
are
So
you
when you
looking
think
for
of
some
that,
target?
it was a benign tumor. Now it has
yes.
recurred, and you think that it is maybe changing to malignant. In those kind of cases, if it is already a mucoepidermoid carcinoma, now again it is recurring. FNAC also saying it is a malignancy. It most probably is a mucoepidermoid carcinoma. It will not change your treatment plan.
Yes.
Whenever you do some investigation, you do keep in a mind that your treatment plan can be changed.
Okay. Yes, sir.
Okay.
Or if you are looking at targeted therapies for metastatic disease, you might want to do core biopsy where you will get targets. When the
Yes.
patient is not operable, it's metastatic, you are looking at giving chemotherapy, then you will need a corneal biopsy.
Yes, sir.
Priyank, you said molecular typing.
Yes,
So
sir.
be specific in mucoepidermoid. What molecular typing you want to do it?
So for in the mucoepidermal carcinoma, CRCT1 MML2 fusion is specific. For that,
Good.
yes, I
Any
will do
other?
the.
So how is it helpful for your treatment plan, this molecular typing?
So if it is a MML2 fusion, there is a favorable prognosis, good prognosis in that. So so I can counsel the patient that prognosis is good for this case.
So you can prognosticate the patient, whether your treatment plan will change or not.
So no treatment plan will not change, sir.
And what else depends? The prognosis depends on what else factors? Only that molecular typing or something else also?
No, ma'am.
Because
If the tumor is high grade, the stage, facial nerve involvement, and whether there is a deep lobe involvement, this factor will also affect the prognosis.
so only on the basis of your molecular typing can you counsel the patient regarding the prognosis?
Not solely on the molecular typing, ma'am. This factor also I will include and counsel about the prognosis.
So how you interpret the FNAC?
So for FNS for interpretation of FNS, there are Milan staging. In that there is a 6 categories: non-diagnostic, non-neoplastic, ATP of undetermined significance. For 4A is benign, 4B is salivary gland of uncertain malignant potential, and 5 is suspicious of malignancy, and 6 is malignancy. So each category has been assigned with the risk of malignancy, sir. So I can and for each category, there is a further plan. So if it is
So
non-diagnostic,
when you will counsel the patient for surgery, in which category?
uh,
Or when you will say that you can observe?
so if it is a first non-neoplastic, if it is a any lymphadenopathy, in this we can observe, sir. And ATP of undetermined significance category 3, sir. I can we can go for the surgery because it has a risk of malignancy of 30%, 25 to 35%. And if it is a benign, risk of malignancy less than 3%. So in that category also we will advise for the surgery.
So
4B,
what are the risk of malignancy between 3 and 4?
yes, sir.
Between category 3 and 4, what are the risk of malignancy? How much percentage?
So category 3 is AUS, risk of malignancy is 30%, and 4A is benign, less than 3%. 4B is STMP, risk of malignancy is 35%.
4A or 3 when you will advise surgery in both?
The 4B,
4A and 3.
yeah, yes, sir. For both, sir, for both I will advise surgeons.
Okay. So when you say that it is malignant,
Yes, sir.
so 5 and 6 are malignant. What is 4B? Why it is different?
Sir, it is the SUMP, the salivary gland with uncertain malignant potential. So in that, cytopathologist can say that it has certain malignant potential, but they cannot define that whether it's a benign or malignant. So
So
for
there are
that,
some atypical cells and all those things will
yes,
be
sir.
there in the fore. Okay. So how will you ascertain the extent of surgery?
Sir, first I will see if there is an intra lymph nodes are there, whether the tumor is a high grade or a higher stage, T3, T4, whether there is a facial nerve is involved or not. And
How do you see the high grade, as you said, no? Before surgery, how do you see the grade of the tumor?
Mostly, yes, ma'am. Mostly in FNSC, it is not, FNSC cannot provide the grading, but in some cases, they can say that it could be a high grade.
Okay, so in general, FNAC usually cannot see, huh?
Yes, ma'am.
Why FNAC is not adequate for commenting on the grade?
Ma'am, as an example, if you take an example of mucoepidermal carcinoma, for grading we need component of it is based on intracystic component mitosis, necrosis, perineural invasion. This can so we need we need proper architecture for the grading. That cannot be provided with FNS, ma'am.
Yeah, so for grading, we need the entire architectural component, which is not possible
With
either
FNS.
in FNAC and not also to some extent in frozen as well. Okay.
Yes.
Yeah, go ahead.
So what was your FNAC in your case, in this case?
Yes, sir. Raymond. Says FNSC was category 6 mucoepidermal carcinoma.
Any lymph nodes in the neck on the scan or clinically?
No,
clinically was not there in the scan.
No, sir. On the scan, there were no lymph nodes.
If there would have been any suspected lymph node, will you do the FNAC?
Yes,
or you will directly.
Or sir, if it is the level 2 lymph node, then I will not do the FNSC. I will just send the frozen intraoperatively. If it is a positive, then I will go with the neck dissection. If it is a separate level 4 or 4 lymph node, then I will so for the no, I will not do the FNSC, sir. I will do the intra frozen for level 2 node sampling, sir.
Not sampling. If there is suspected lymph node, is better you are doing a FNAC for the parotid. It's better to do the FNAC for the lymph node. You are at least clear before operation what extent of operation you are going to do.
Yes, sir.
Rather than to be on towards the frozen section, that is fine because that is in your field. That's why you have told that at level 2 you will not do the FNAC. But if it is already suspected node, it is better to do it pre-op.
Yes, sir.
Okay, so it was a mucoepidermoid carcinoma. And what is your plan now? Depending on your, can you go with show the radiology?
Yes, sir. So it is a T2 weight. So sir, it is a T2 weighted axial image of the axial image showing hyperintense lesion in the left parotid. In that lesion is superficial and limited to the superficial lobe, sir. And there is no lymph nodes. And this and this is a T1 weighted axial image, sir. And there is the iso-intense lesion seen in the left parotid regions.
So can it be a deep lobe? Can it
Uh,
possible it is a deep lobe?
So as looking at the scan, I am seeing that the lesion is superficial to the retromandibular veins. So there is that's why I can make it out that it is in the superficial lobe and not going into the deep lobe.
Okay.
So what differentiates superficial and deep in imaging?
Yes, sir.
So you said this is superficial, which is right. But
Yes,
how
sir.
can you in a imaging read and say that this is in superficial or this is in deep? What are your landmarks?
So in here, ma'am, retromandibular vein, ma'am. So swelling
Okay.
superficial to the retromandibular vein is uh, will be in the superficial lobe
Can you
and
show
deep
it here with your marker? Where is the retromandibular vein?
this one, ma'am. But can you see the ma'am the arrow?
Yeah. Okay. Okay.
So what is your plan now?
So it is the mucoepidermal carcinoma limited to the superficial lobe. I will go with the superficial parotidectomy, sir. With superficial parotidectomy, sir, for this case.
If it is a high grade,
So if it is a high
we
grade,
don't
then
know.
there. So for that, I can use the intraoperative frozen for the margins, sir. If it is the if it is
How it
for
will tell you the grading?
so frozen has an accuracy of 96% for the malignancy.
So
So in
malignancy, it is
here,
already malignancy. Malignancy is already
Okay,
there.
sir.
I am
So
talking
grading.
about it's a grading. So there will be your plan if it is a high grade or
So if it is high
low
grade,
grade.
then I will so ESCO guidelines says for the low grade mucoepidermal carcinoma uh, uh, with uh, uh, with a margin less than 2 millimeter, surgery alone is efficient, like a superficial parotidectomy. But if it is a high grade tumor, there are chances of internodal metastasis is high, which are in the deep lobe also. So to clear all the nodal basins, I will in high grade cases I will go for the total parotidectomies.
So you are right. You have told that you will do a superficial parotidectomy. You have to justify it now.
Okay.
So just grade is not known.
Yes.
Why not total parotidectomy? So you have to go with your clinical history, examination, radiological finding, everything put together, and then you say that in high probability it is a not the high grade. It may be
Yes, sir.
a intermediate grade, you don't know, but it not looking like a high grade, depending on your whole clinical examination, history, radiological examination, and that's why I am doing this. I have planned it for the superficial parotidectomy.
Yes, sir.
Okay, it's not only the FNAC or pathology can tell you, there are other signs also. Okay.
Yes, sir.
When will you decide to do a total conservative? What if you get a positive margin when you're planning a superficial parotidectomy in a malignancy case? What will make you decide to do a total conservative, maybe intraoperatively?
If it's a margin positive, then
No, I'm asking you intraoperatively. How will you decide that you don't want to do a superficial, but you want to do a complete total parotidectomy with nerve preservation?
so as I said, ma'am, if it is I will do the intraoperative frozen. If it comes as a positive, then I will go with the total.
intraoperative frozen, what would come as for positive?
So margin at the
Why would you see the margin in the frozen? if there is, what are the conditions where, with Dr. Vidisha is asking, what are the conditions where you would convert?
So how many
Do you
times you have seen
routinely,
the for the margin in the parotid during for the frozen? Have you seen in your uh, 1 or 2 years whenever you have ever you have done parotid margins for the parotid? So which you have not done, it has not been done. We never do that. Okay, so if it is very close to the nerve and you have to sacrifice the nerve or not to sacrifice the nerve, then you do the frozen section. So what is the role of frozen section actually in the parotidectomy?
So for the first is as a level 2 node sampling. If it is an intermediate grade, we can send the node for the frozen, and if it comes
Okay.
positive, we can go ahead with the neck dissection. So if there is a perioperative facial palsy and we cannot get the plane with the tumor, and if we are planning to sacrifice the nerve, we can send the perineum for the frozen section. If it comes positive, then after considering all these factors, we can sacrifice the nerve, and it can also guides the surgery, extent of the
So if you
surgery.
are sacrificing, if it is like, so Dr. Vidisha has asked, if it is it is stuck to the nerve, not you are not able to separate the nerve and you have to sacrifice the nerve, it's looking like a high grade now. It is not a
Okay, sir.
low grade tumor. Then you have to do a total parotidectomy. That's the one thing. And other things, what you want to say to Dr. Vidisha, that when you convert it to the total parotidectomy intraoperatively,
Yes, sir.
any other reason when you will convert it?
So Priyank, think about what will be the indication for total.
Uh,
You can answer.
wait,
Suppose you have sent node for frozen, that comes positive.
yes, sir. Yes, sir. Lymph
If
node
there is
positive.
you have found some intraparotid node,
Okay, sir. Yes, sir.
and clinically when you are operating intraop, you are looking for the tumor is extending or touching the deep lobe.
Yes, sir.
So think about where you do a total. That's the answer only.
So in this case,
so as Dr. Madan has said, if you find the intraparotid node
yes, sir.
intraoperatively and it comes out positive on frozen, this is also one of the work you can do with frozen. So what would you do there?
Yes, ma'am.
Dr. Madan just asked, no, if intraparotid node comes positive on frozen
Yes, ma'am.
and you were planning to do a superficial, now what would you do with your surgical treatment
So
plan?
then I will do the total, ma'am. If it is not comes
Why
positive,
do you do that? Why do you do that?
because ma'am, if interpreted nodes are positive, there are twofold increase of the recurrence and two to three times the mortality chances are increases, ma'am.
So what is the distribution of intraparotid nodes in the parotid?
There are average there are 26 nodes in the parotid.
I mean,
It
no, the
is
percentage of distribution between the superficial and the deep. Because you said you'll be removing the total parotid, right?
yes, ma'am. So ma'am, and
Hmm.
superficial
Yeah, tell me. Percentage of distribution in the superficial and in the deep intraparotid nodes. Where do you find it more?
mostly in the ma'am, it will be between the retromandibular vein and deep lobe, ma'am. Mostly.
Between the retromandibular and deep.
Yes, ma'am.
So what location is that?
Deep lobe, ma'am. It is the mostly what it will be in the deep.
Most nodes in the parotid you find in the deep lobe. Where do you find Dr. Priyank? So, for example, another question, you are doing a SCC of the orbit, okay?
Yes, sir.
And do you do a prophylactic parotidectomy in those cases? SCC of the orbit or sebaceous carcinoma of the orbit? Do you do a or a cutaneous SCC in the facial area? Do you do a superficial prophylactic parotidectomy? Superficial
Yes, sir. Yes, sir.
parotidectomy?
Superficial.
So why do you do in an occult case? You still go for a superficial parotidectomy prophylactic? Do you do that?
Because of the sorry, ma'am. Because of the most nodes are present in the superficial for that.
Superficial nodes have most number of this one, okay?
Yes, sir.
Not deep. This was basic, okay?
Yes.
So Dr.
So
Priyank,
if
if you have to do a neck dissection, in this case, what will the levels you will take out?
So if it is a clinically N0 node, and if it is a high-grade tumor, then we will go for level 2 to 4. If it is a clinically positive node, then I will go with the 1 to 5 nodes.
So elective neck dissection, even for the elective neck dissection, high-grade level 5A is very important in parotid.
Yes.
Even in the isolated 10 to 15% times the nodes can be there in level 5A, not 5B. So
Yes.
5A should be removed always in the parotid.
Yes.
Okay. We are about to finish here. 3-4 minutes more. What is the final pathology report?
So final pathology report was the low-grade epidermal carcinoma, mucoepidermal carcinoma.
Do you have with you?
No, sir. That's again.
Okay. So what were the margins? What were the any
So
lymph
margin
nodes?
was
What were
negative
the
margin.
size of the tumor?
The size of the tumor was around 3 by 2.
So it is a low grade mucoepidermoid. Margin is 1 millimeter. What will you do? It can happen at the nerve.
So in for
ASCO guideline, na?
yes, sir. For closed margins, for low-grade epidermal carcinoma, we can observe, sir, there is a case series by Zhang et al. In of the 15 patient operated for low to intermediate mucoepidermal carcinoma. When there is a 100% local regional control rate with only surgeons, sir.
Even for the intermediate?
Sir, for yes, sir. They in intermediate, sir, for recent NCCN guidelines suggest that we can give the RT, but for the ESCO guidelines, they have clubbed. There are two series. One is of the Zhang et al. And second is the Stodusky et al. Sir, and that they have only observed with the intermediate grade MEC. And
so what are the indications for post-op RT?
So for post-op RT, high-grade tumor, T3, T4, positive margins, perineural invasions, lymphovascular invasion, and lymph node metastasis. And all the studies, all the cases of adenocystic carcinoma, regardless of states.
Because we are running a bit short of time, I would request the examiners to grade the examinee for today's case.
Dr. Priyank, the history taking and everything was fine, was good. But you have to a bit work on your clinical part as well as the theory. Okay.
Yes, sir.
Otherwise, okay.
Yeah, I agree with.
So I think you have presented well. The only thing is your plan was also fine, but you have to give your answers in a structured way. You have to justify your answer. You were not
Yes.
able to justify your answer. Your case was fine, your plan was fine, but you have to justify in your exam. So
Yes,
why
sir.
you want to do this? Okay.
Yes, sir.
So I would request the examiners to please grade him out of 10.
I will grade him 6 out of 10. Like I agree with what Kaveri was saying. You have presented well, your history taking is good, but you need to brush up on your justifications for your treatment plan. And you need to read a little bit about relevant literature as well.
Yes, ma'am.
From my side, 6.5.
So from my side, 6.
Yeah, 6.
Okay, thank you, Dr. Priyank. Thank you, all the examiners. We had a wonderful session. Thank you.
Yes, thank you, sir.
Thank you. Thank you.
Uh, Thank you to the expert panel and the moderator for an insightful. So I extend my sincere gratitude to our esteemed panel members and moderator for the insightful contribution and for guiding the discussion with such clarity and depth. Now, moving forward, now moving forward to our next session, which is a operative technique discussion on total laryngectomy. And in our expert panel, we have Dr. Vipin Arora, who is a director professor in the Department of ENT and Head Neck Surgery, University College of Medical Sciences and GTB Hospitals, Delhi University. Dr. Prashant Pawar, who is a senior consultant, Department of Head Neck Surgical Oncology, HCG, Khubchandani Cancer Hospital, Mumbai. Next, we have Dr. Amit Tyagi, who is a professor in the Department of Laryngology and Head Neck Surgery, AIMS Rishikesh, Uttarakhand. And Colonel Dr. Rajiv Chugh, Senior Advisor ENT and Head Neck Oncosurgeon, Army Research and Referral Hospital, New Delhi. And the speaker of today's lecture, this session, would be Dr. Kannan S., who is a consultant at the Department of Head Neck Surgical Oncology, Apollo Cancer Hospital, Chennai. Sir, please share the screen now.
Thank you, Dr. Poonam, and the entire team for having me here. Is my screen visible?
Yes, Dr. Kannan, it's visible.
Yeah, sure. Thank you. So today we will be discussing about total laryngectomy, the surgical techniques. So if we look at total laryngectomy, there is only 3 indications. One, when the tumor erodes the cartilage or there is extralaryngeal spread, whenever there is organ failure, or when you have a incompetent larynx or dysfunctional larynx, that's when we would do a total laryngectomy here. So now there are various steps in which we do a total laryngectomy. It starts from incision planning, whether we would do a neck dissection or not. How do we decrease the vascularity of the tumor? How do we handle the thyroid? When do we transfer the airway? How do we skeletonize? And how do we resect? So we will go step by step and look into each. So now, first step in doing a total laryngectomy would be to do a direct laryngoscopy. Let's make this little more interactive and can we, from the experts, sir, what would you look when you do a direct laryngoscopy just before you do a total laryngectomy? Prashant.
Yeah, Kanan, can you hear me?
Yeah, Prashant, I can hear you now.
Yeah, so the direct laryngoscopy, I think the first and foremost thing what we would want to do once the biopsy and everything, we are presuming it's proven. So first and foremost thing what we want to do, the extent of disease. Mapping of the disease is very important. The next thing would be to whether it's operable, clearly resectable or not. And then last thing would be to assess whether you require a reconstruction. Okay, especially if it's extended into the pyriform, then how much of margins are we going to take, and do we have to plan for a reconstruction like a pectoralis major or a free flap for that matter?
So before doing a total laryngectomy, all these patients should undergo a direct laryngoscopy. Yes, sir.
Dr. Kanan and Dr. Vipin Arora here.
Yes, Dr. Vipin.
So I just wish to add that the assessment of the patient who is supposed to undergo laryngectomy starts well before that. So these patients have already undergone imaging for tumor mapping. They have already undergone assessment of laryngeal function, unless they have been tracheostomized by a flexible laryngoscopy. So that is mandatory. And then this direct laryngoscopy is the one which we are doing, which is a gold standard for the surgery, which is done prior to the surgery, in which we take the biopsy and assess all the sites and the subsites of the larynx. We assess the subglottic extension also, if it is present, by using the rigid scopes. Then you assess the pre-epiglottic or paraglottic space. You can actually palpate it. Then you can palpate the base of the tongue also, if there is involvement of the base of the tongue. And I would also like to take this opportunity to palpate the neck under general anesthesia.
Perfect. So assess the base tongue, that would make it even inoperable. So you look whether the pyriform sinus is involved. So that will help you in fine-tuning a surgery as well. You will not resect the constrictor muscles on the thyroid. So very good. So direct laryngoscopy would be our first step. Now, what would we do when we have a patient with prior tracheostomy? So how would we plan and how would we go about? So when we have a patient with tracheostomy, always assess whether there is any infection around the tracheostomy or not. Most of the times there will be infection, there will be inflamed skins. So while the patient is getting worked up for the laryngectomy, treat them with adequate antibiotics, send cultures. So if the edema, inflammation decreases, the surgery becomes much simpler, and the tracheal infection, everything is pretty less. So now if you have the platysmal involvement, in such cases, we would like to resect the skin and we can plan the incision accordingly. This is what we do when we have a skin involvement, or if we have a prior tracheostomy. If we don't have a prior tracheostomy in a normal patients, how do we plan the laryngeal incision? So let's start with Amit, sir. So how do we plan the incision, sir? What would be your preference, whether you will do a separate incision for the neck, for the stoma and the neck dissection, or whether you go with Gluxor, and how do we go? But what's your thoughts on that, sir? Amit, Prashant, anybody?
Yeah, Kanan.
I'm not audible, I think.
Yeah,
am I audible?
I think.
Am I audible?
Yeah,
Yes, sir. Yes, sir. You're audible, sir.
Okay. So there are two ways of going about it. One is Gluxor incision, U-shaped flap, and the one is transverse incision. Other thing is we can make a different tracheostoma site also with a transverse incision above. It could be little oblique also, apron flap. So there are two ways of doing this. So in long neck, maybe a separate tracheostomy site with a separate transverse incision could be taken. But in a short neck, it is maybe difficult. So usually it's based on surgeon preference. So long U-shaped flap Gluxor incision is usually I prefer because it gives more space for neck dissection, and especially, which is very important, the level 6 neck dissection. So it gives me more space. So that is a more preferable.
Perfect, sir. Perfect. Prashant, do you want to add anything?
Yeah. Basically, I like to have the separate incision and a separate stoma. and we need to have adequate space between the stoma and the horizontal incision. And like we likely discussed the glux horizontal incision, we also kind of, in like a modified glux horizontal, we prefer a horizontal incision, but slightly curve it upwards behind the posterior border of the sternomastoid. So that gives you adequate access as well, and the scar is also slightly better.
So perfect. So you tend to avoid an incision from the mastoid to the mastoid so that the lower
Yes.
part of the
Yes.
neck becomes dicey. That part has a chance of necrosis.
Yeah.
Perfect. So incision planning is quite important. What we have learned is if there is a long neck, it's okay to do a separate incision. If it is a short neck, you can even have a single crease incision and you can have the stoma along the crease. And you all tend to curve it little upwards rather than taking it up to the mastoid. Pretty
Dr.
good.
Kanan, one more
Yes,
thing
sir.
in incision,
Yes.
that when we are putting that large U-shaped incision,
Yes.
glux or incision, so
Yes.
the lower part tend to stretch on the stoma. So sometimes there is a dehiscence on the stoma.
Correct.
So
Correct.
those small nuances and these things
Perfect.
we need to take into account, that if it is getting too tight, skin is tight or skin is not good or healthy, is not pliable, so then we can move to the two incision and separate stoma thing.
Perfect. So vascularity is quite critical. So if you take a U, this part becomes dicey. Perfect. So now that we have done the incisions, how far do we raise the flap when we do a laryngectomy? Amit sir?
So
on the upper end of the flap, yes sir.
So superiorly, it should we should expose the submandibular gland,
Perfect, sir.
and inferiorly it should go till the clavicle, suprasternal notch, so that we can have the whole, and laterally it should go to the posterior border of the sternocleidomastoid.
Perfect.
So that should be the exposure.
Great. So you should have an adequate exposure. Adequate exposure is the key. So you expose it up to the hyoid, as I told you, you'll expose it up to the submandibular gland on both sides. And preferably you identify the external jugular vein and you trace it up to the parotid so that the lateral exposure is also good in case you have to do a neck dissection.
Other thing, Dr. Kanan,
Yes.
there is no need to elevate the flap over the submandibular gland, because sometimes in initial phase, the marginal mandibular nerve may be at risk.
Perfect.
So you can take submandibular gland into the flap.
Perfect. So you need not clear 1B in a total laryngectomy, and hence please don't rise over the submandibular gland. Great. So now about neck dissection. So when would we do the neck dissection in a case of total laryngectomy? Vipin, anybody?
Yeah, Dr. Kanan, if there is a clinical involvement of the neck on either side, obviously you'll have to do a comprehensive type of neck dissection bilaterally.
Perfect.
And there is another condition in like a supraglottic cancers which drain bilaterally. And in these cases, you will have to do a bilateral neck dissection, or even if there is a palpable or clinical lymphadenopathy on one side, but you must do a prophylactic neck dissection on the other side.
Perfect.
So these are the two conditions. And if there is a significant subglottic extension also, then also we'll have to do a
paratracheal central compartment, very much clear. Perfect.
Paratracheal dissection.
But Prashant, what is your philosophy on neck dissection for post-RT patients? Nowadays, we are getting a lot of post-radiation patients.
Yeah.
What is your philosophy on that?
So for post RT salvage laryngectomy, you will generally rely on the PET-CT findings. Okay. So the PET-CT is positive, then we'll address the neck. But if the PET-CT is negative, we'll not address the neck.
Perfect. Perfect. So if you don't have a node pre-radiation, and if the recent PET-CT shows no nodes, you wouldn't address the neck in a recurrent laryngeal cancers.
Especially because in salvage, in salvage, the healing is much better.
Yes. More to handle the neck decreases the vascularity. Unless it's oncologically needed, don't handle it. Perfect, Prashant. Yeah. Anything else, sir?
Yeah, Dr. Kanan, as this is, we are approaching to postgraduate resident.
Yes,
so
sir.
as a rule of thumb, if we make it little simpler,
Yes.
so because most of the cases we are doing total laryngectomy in T4. So
Correct.
already the cartilage eroded. So
Correct.
even in T3, some cases we are doing in a extensive cases in dysfunctional larynx.
Perfect.
So the kind of patient we have, it's a very easy to make a formula that in all patients and in a naive patient, per primum patient, it is doing the bilateral 2, 3, 4 in any case. Supraglottic, glottic, and subglottic, because the extension usually goes to subglottis.
In the
Now,
purpura
and thyroid cartilage invasion is there, which actually needs bilateral neck dissection to 2, 3, 4. If N plus is there, then on that side 2 to 5, and other side 2 to 4. So that is for N0 and per primum. And for salvage laryngectomy, if there is a N0 previously, then you can before, yeah, in an initial this thing, and then recurrence. So in recurrence setting, we need to find out that previously it was N0 or N1. If it is N0, then we can take off help of PET CT, or even we can just leave that, because the more you do neck dissection, there is a chance of pharyngocutaneous fistula also. And in N plus cases, we need to do that.
Perfect, sir. So in a per primum, you would address level 2 to 3, level 2 to 4 in all cases. In post RT, you will fine tune it as per the pre RT findings of the nodes. So now that we have done with the neck, so I usually start from the lower end of the flap. Lower end, we cut the sternohyoid and sternothyroid. So before cutting the sternohyoid and sternothyroid, expose the internal jugular vein and carotid artery. The last few fibers of the strap muscles are pretty close to the carotid artery. So identify the carotid artery before you cut laterally. Cut the straps as low as possible. On the side of the disease, you pretty clear the central compartment as much as possible. And you don't elevate the strap muscles on the side where you're going to resect the thyroid gland. So you resect the strap muscles as low as possible, and you clear the central compartment there. On the side where you would preserve the thyroid cartilage, the thyroid gland, you tend to elevate the strap muscles over the thyroid gland. Any inputs, any techniques, anything you want to add from the panelist?
Dr. Ganan, I just wish to add that rather than I use a similar technique, but I insinuate my finger below the strap muscles.
Perfect.
So,
very important. You protect the carotid by all means. Insinuate your finger to see
this will
safe
protect
with
the
the
vessel.
carotids. Perfect. So identify it. So this is how you handle the lower end of the so now let's get into the upper end. So now we have to delineate the hyoid bone. So when you look at the greater corner of the hyoid bone, always for the postgraduates, it is pretty close to the hypoglossal nerve and lingual artery. So you have to preserve the hypoglossal nerve and lingual arteries to stay as close to the bone as possible. Delineate the bone, identify the greater cornea, stay on the bone, separate it off the periosteum, so that the chance of injury to the hypoglossal and the lingual artery becomes lesser. Once you do this, then you concentrate on your greater cornea. So greater cornea of the thyroid cartilage. Separate it, get it freed all around. Once you delineate it, then on the side, in a patient with a pyriform sinus, on the side where the tumor is there, you wouldn't delineate the greater cornea. If on the side where there is no tumor or in a laryngeal cancers, you'll delineate the greater cornea of the thyroid cartilage. So once you identify the thyroid cartilage, greater cornea and the hyoid bone, you'll have the laryngeal pedicles in between. That will help you in proceeding further. So once you do this, then you go to the upper end, disconnect the suprahyoid strap muscles from the hyoid bone. So now we have freed the inferior part, we have freed the superior part, we have preserved the hypoglossal and the lingual artery. This is what you do for the hyoid delineation. So anything from the panelist? So I'll finish these 3 steps, then we'll discuss. So next would be to handle the vascularity. So how would we, there are 3 on the side of the disease, you will ligate both superior thyroid vessels and inferior thyroid vessels. On the side where the disease is not there, you'll just ligate only the superior laryngeal vessels. So identify the superior thyroid artery and ligate it. On the side where the disease is, where you are going to resect the thyroid gland, you identify the inferior thyroid artery and ligate that as well. So on the thyroid side where we will be removing the thyroid gland, you identify the first you identify the middle thyroid vein, ligate the middle thyroid vein, then we would proceed for the inferior thyroid veins. And we would do a good central compartment clearance on that side. If possible, preserve the parathyroid. If there is a lot of central compartment nodes, parathyroids can be auto-transplanted as well. So once we do this, then we deskeletonize the larynx. So you resect the inferior constrictor muscles from the thyroid ala or along the oblique line on the side where the disease is not there. In a pyriform sinus tumor, you wouldn't do this step. Once you resect it, you expose the pyriform sinus mucosa, you have the disease here. When in a patient with a hypopharyngeal cancers, we wouldn't do this because you would get a straight positive margin here. So this is how you delineate the thyroid and devascularize the thyroid. From the panelists, anything you want to add? So any tips and tricks in fine tuning these steps? So we will be discussing about the strap muscles lower end, hyoid bone, and the inferior constrictor and devascularization.
So
Perfect.
Dr.
I think
Kannan,
Kannan, you
sorry.
summarized very well.
Thank you. Vipin, you want to add anything?
No, it has been very well
Okay.
summarized and very well shown that you should never go to the in a pyriform sinus cancer when it is involving the lateral wall, never enter into the side where the disease is there. Always go to the other side and then release the inferior constrictor from the thyroid and then make an entry from there. So entry should always be from the other side. And mucosa
Yes,
can
doc.
always be mobilized from the opposite side only, not from the same side. Otherwise, you'll straight cut through the tumor.
Yeah, just that the inferior constrictor will handle with a lot of tender loving care because that is very important as a second layer for our prevention of a varicose fistula.
So now next
So
step
Dr.
is
Kannan,
thyroid.
I just would like to add.
Yes.
So in strap muscle cut in the lower part, the deeper muscle, which is a sternothyroid, it is a broad and thin muscle. And when you cut it, we need to be careful about touching the cautery of to the thyroid bed, which can lead to the bleeding and you waste 5 or 10 minutes there.
Perfect.
Number two, this lingual artery and hypoglossal, there is one simple technique which resident can do. And I learned across this, that first cut the lesser harnu, which the muscle attached to the lesser carnu, which are stylohyoid and digastric. Once you cut them, the whole hyoid actually you can pull inferiorly. And once you pull inferiorly, the greater cornu, the tip of the greater cornu is detached from these neurovascular bundle. So in that way, it is easy. So that is one technique. So always from lesser cornu, divide those muscle and pull the hyoid inferiorly and do those things. So this is
perfect. Perfect. So now that we have devascularized, we have deskeletonized. Now let's get into how do we handle the thyroid gland. You on the side where we are going to preserve the thyroid, tend to cut it at the level of the isthmus. But in some cases, when you have a previous tracheostomized, when there is inflammation, you have to get onto the lobe of the thyroid and resect it. So resect the thyroid and preferably resect it at the isthmus and pedicle it to the inferior pedicle and the superior pedicle. So you don't go too much down into this area so that you'll unwantedly injure the vascularity to the parathyroid. The main purpose of preserving the thyroid is to preserve the vascularity to the parathyroid rather than for the thyroid function itself. So now I would like to get the opinion of the panelist on how do you handle the thyroid. So for example, when do you do a total thyroidectomy? When would you not do a thyroidectomy at all? So let's start with Prashant. When would you not do a thyroidectomy? When would you preserve both lobes?
So if on the CT scans, we are clearly saying that it's only a glottic lesion, there is no major extension outside the thyroid. So in these cases, you may be able to preserve, but as a policy, I have a policy of doing ipsilateral thyroidectomy in all my patients. Okay. But in patients who have gross pyriform involvement, extrathyroidal extension, definitely you have to remove the thyroid. And I think the previous, policy of removing thyroid just for the sake of thyroid, it's a debatable issue. Okay, but at least one side, even a sliver of thyroid along with the parathyroid, like we said, if you can preserve, I think that is great for the patient.
Perfect. Dr. Rajiv, when would you do a total thyroidectomy? When would you remove both lobes in a patient with whenever you do a laryngectomy?
So can you hear me?
Yeah, we can hear you, sir. Yeah.
So, as all of us, all of the other panelists spoke, that ipsilateral disease, we save the opposite side of the thyroid.
Yes.
But in certain cases, when there is a midline involvement, it has breached the anterior, in the anterior commissure, it has breached, and it is involving the central component, central portion,
Yes.
where the isthmus and the areas adjacent to it may be involved. In
Yes.
that situation, I would not take a chance to go beyond it into the
Cross
lobe and protect it.
laryngeal spread involving isthmus and both lobes. Perfect.
So in that particular situation, I would like to do a total thyroidectomy.
Perfect. So any other thoughts?
Yeah,
Dr. Amit, Dr. Vipin?
Yeah, Dr. Kannan, the removal of thyroid, I mean, again, it is to be emphasized that the kind of patient we are getting is cartilage already is invaded and the tumor has come outside.
Yes.
So in all these cases, total thyroidectomy is required because it's a cartilage invasion. The other thing,
Let me get it right, sir. So cartilage invasion along the anterior commissure or on any side you do total?
No, not, it's the midline you need to do,
The
but
anterior
the
commissure
more
area coming
inferiorly.
up to the isthmus and involving both lobes. Perfect.
Yeah.
Yes.
And other thing is if it goes more inferiorly, suppose it is coming out from the cricothyroid space.
Correct.
So
Exactly.
cricoid
Yes.
cartilage invasion, then also you need to do total thyroidectomy. The concept actually, why do we need to remove the thyroid lobe is because not only the thyroid parenchyma invasion, it is because of the level 6 nodes also. So you need to clear level 6 node, and to clear that you need to remove the thyroid also. So both are actually linked, and in both, either you do prophylactic paratracheal dissection or ipsilateral thyroid lobe excision. The concept is if it is going inferiorly, that means piriform fossa apex involvement, subglottis involvement, the circumferential subglottis involvement, piriform fossa apex involvement, and if it is eroding the cricoid cartilage coming out of the cricothyroid space, that means it is going inferiorly. The chance of getting level 6 paratracheal involvement is more, and parenchyma involvement is also more, which is around, in several studies, is around 13 to 15%. So it is important to note this. So if it is purely ipsilateral and it is coming only superiorly, that outside thyroid cartilage, then we can do ipsilateral, but more inferiorly if it is coming out, then total is required.
Perfect. So particularly in a patient with a post-cricoid malignancy involving both piriform apex, there will be tumor seedling along the point where the recurrent laryngeal nerve enters into the larynx. So if you have to remove that area adequately, you have to do a total thyroidectomy. So in a post-cricoid malignancies, we would do a total thyroidectomy. As Prashant told, if it's a very small glottic tumor in a post-RT setting where the pre-radiation also there was no cartilage erosion, you can even think of saving both lobes of thyroid cartilage, both lobes of the thyroid.
Dr. Kannan, one more thing. Sorry.
Yeah, yes.
It is very important to understand that it is about the parathyroid preservation, which needs to be more emphasized during thyroid. So what we usually do in our institute, that with microscope, we follow the inferior thyroid artery, and inferior thyroid branch we see properly. We actually separate parathyroid on both sides, superior and inferior, separate them, and then we remove the thyroid. So it is very important to focus on parathyroid in these areas.
Very good. Perfect.
Dr. Kannan, I just wish to make a point. One is just in continuity to what Dr. Amit has said. The per se involvement of thyroid parenchyma in a laryngeal cancer is very rare. But just to cover the anterior margin, we do an ipsilateral hemithyroidectomy. But the second point, as Dr. Amit said, is it's all about parathyroid.
Yes.
These patients after radiotherapy, all of them will turn into hypothyroid state.
Yes.
So they will all be taking thyroxine. So it is all about the preservation of parathyroid. I think that I am at least focused on while doing a total laryngectomy and preserve the parathyroid on the other side. This is what my take is on this step of surgery.
So as all the panelists reinforced, the handling the thyroid is mainly to preserve the parathyroids, and removing the thyroid is mainly to clear the central compartment and to prevent the disease extension along the recurrent laryngeal nerve or along the anterior commissure. So now that we have handled the thyroid, the next step would be to transfer the airway. So now you identify the tracheal ring which you have to resect. In case you have done a tracheostomy, you just go a ring below, and as far as possible, you cut along the trachealis muscle, between the two thyroid cartilages, between the two tracheal rings. I usually tend to avoid cutting through the cartilages to bevel it, so that causes necrosis and post-operative stenosis. I resect the complete ring on top and preserve the complete ring below. Once you do this, then you would end up in the posterior wall. Posterior wall, you just take the mucosa alone. So now you tend to cut the tracheal, the space between the two tracheal rings. Try to keep as much soft tissue above the tracheal ring if possible. Once you do this, then you get onto the posterior wall. The posterior wall of trachea will have tracheal mucosa. You have the intervening tissue and you have the esophageal tissue. So you just resect the mucosa and the intervening tissue. Yeah. The trachea has a segmental bed supply. So if you cut the tracheal ring and make it beveled, there is an increased chance of that cartilage getting necrosed, and this would happen. So whenever you put in the tube, you see to that you don't, it doesn't get into go in for a single lung ventilation. So this is how you do a airway transfer. Once we do the airway transfer, then we go in for the tracheal, then we go in for the laryngeal resection. So as we have seen, we have delineated the hyoid bone on top. Now we release the suprahyoid muscles, and then we try to get into the vallicula, identify the median pharyngoepiglottic fold, and then identify the mucosa over the epiglottis and try to get the epiglottis off. So now the suprahyoid muscles are released. Once you get closer, you tend to see the epiglottis. Once you see the epiglottis, you tend to open up the larynx on the side opposite to the disease. So preferably do it with the scissors. If you use a cautery, resect the cauterized margins before you suture. So always try to enter the tumor on the side away from it, and then you visualize the tumor and you take adequate margins as you go along. Once this step is quite critical. So when you do this on the side where there is no disease, you can resect the mucosa and you can start removing. On the side where there is disease, you cut the mucosa, you cut the muscles at the same line. As far as possible, always the residual mucosa which is preserved should be supported, and there should be a muscle below. So on the side where if you have a disease along the pyriform sinus, you would cut the mucosa there and cut the muscle there so that you have the soft tissue margins clear. So as far as possible on the uninvolved side, try to preserve the greater cornu. Once you preserve the greater cornu, your mucosal preservation also increases. Once you delineate the tracheal, once you delineate it, the post-cricoid cut, if look at the adequate margins and then give the post-cricoid cut as much as possible with the scissors whenever it's feasible. Avoid cautery injury to the mucosa. The necrotic mucosa is the one which is the most commonest culprit for the leak, and unvascularized mucosa is the next commonest reason for the leak. Try to prevent these things. Once you have done the post-cricoid mucosal cut, put a finger along the esophagus and put one finger along the tracheal cut end, and then you open up the party wall in between and then go along the party wall. Be gentle and slow. Once you cut this, you'll expose the carotid here. So be gentle and slow and then remove this area. Once you remove this, you expose the party wall and the specimen gets out. So now we will discuss about the laryngeal entry, mucosal incisions, and this thing. Panelists, anybody wants to add anything? And
nice demonstration, Kan. Yeah, just I think you rightly pointed out when you do the laryngeal entry. So we have the lower border of the upper ring, or we always sometimes you can say the upper border of the lower ring. But it's important to preserve that perichondrium over the ring, and we try to avoid an exposed ring because that tend to have necrosis and then suture line can give. So that is about the entry. We tend to do a upturn curve along the membranous part of the trachea so that we have a broader and a larger stoma. And the D-shaped incision planning is also very important from that point of view. And once you have done the tracheal entry, we would tend to hitch it at least a couple of sutures with ethylone so that that remains stable before you proceed further. Laryngeal entry, I think you very nicely showed that we go from the contralateral side first. Use minimal cautery or cold knife wherever possible because we want to preserve the vascularity of the mucosa. And like an open book, you first do the contralateral side. That gives you better visibility on the side of the disease so that you are able to stay away. Again, this piriform mucosa is always friable, so try to stay a little away so that you get good adequate margins on the ipsilateral side. I think that's about it for these two steps from my side.
Perfect, perfect, Prashant. Dr.
Dr.
Amit, Dr.
Kannan,
Vipin. Yes.
sorry to interrupt. This presentation is going so well. I feel like guilty interrupting you all. So
we will
sorry,
wind
but
it off early.
yeah, we have to stick to the time. So just
Yes,
last
yes,
5 minutes. Would
Yeah,
request
last 5 minutes we'll finish.
Yeah, thank you so much.
Thank you.
Yeah.
Dr.
Kanan, can you make a point, please?
Yes, please. Yes, sir.
So what the previous speaker just told, that what I think is it is very important for the surgeon to change his position from the right side of the patient to the head side of the patient. And the
Yes.
second
correct.
most important point is that you hold or grasp the epiglottis and pull it anteriorly. Only then you will be able to see the entire growth.
Perfect.
And only then you will be able to resect and you'll be able to take a proper margin. And as far as the entry into the hypopharynx is concerned, it can be through vallicula, it can be through the lateral wall of the hypopharynx, and particularly once the cricoid is involved, then obviously you'll have to go a bit more lateral and inferior and open the hypopharynx in a book sort of manner. And
So before you give the mucosal cuts, have adequate visualization. Change your positions, get adequate exposure, open it from the opposite side. Perfect. So good visualization before you get the mucosal cuts so that you don't get a close or positive margins, or you don't resect more whenever it's not needed.
Yes.
So now
And
that we have
headlight-
removed the larynx, most
Dr.
of these
Kanan,
patients.
can I add
headlight give
quick
you
3
better
points?
view.
Yes, sir. Yes, sir. Let's be
Quick
sharp.
3 points. Sir,
Yes,
Vipin sir, first, sir. Vipin sir is saying something.
And no, I was just winding up my comment that if you are using headlights and you are on the head end of the patient and looking directly into the endolarynx, that is the best view you can have.
Perfect.
And you will
Visualization
get
is
everything
quite
under
critical.
vision.
Quite
So,
critical.
sir, 3 quick points. There should
Yes.
not be any unsupported mucosa.
Perfect.
Number 1. Number 2, entry should be according to your mapping. It could be from vallicular contract, it could be from piriform fossa, pharyngotomy, or it could be from the posterior pharyngeal wall. Because if it's
Away
base
from
of
the
tongue is
disease.
involved,
Away
then you
from
need
the
to go
disease.
away from the disease. And the third
Perfect.
point, when you're lifting this while finding the plane between this avascular plane, and you are lifting this trachea, sometimes you are cutting the blood supply from the vertebral side. So we need to be very careful that the whole pharynx should not
get lifted. Correct.
Yeah.
So
yeah.
that's why you keep a finger and support it onto the patient on the esophagus and one finger on the, so that you open up the space. Perfect. So now
One last and important point: prevent separation between the trachea and the esophagus.
Very important. Very important. So now that we would do a myotomy whenever you are planning to do a voice prosthesis. So it can be done lateral, medial, so that you release the muscle and see to that the mucosa bulges out. Okay. So now pharyngeal closure. Pharyngeal closure, as we all the panelists pointed, there should not be any unsupported mucosa. The remnant mucosal size should be adequate. Prashant, what's your thoughts on the size of the remnant mucosa for the closure?
I think unstretched mucosa at least 3 centimeters. Some people would extend it to 2.5 centimeters. Unstretched mucosa is adequate. You can do a primary closure.
Perfect. So unstretched mucosa should be quite important. So whenever you have unsupported mucosa, better to trim it off. So and then start the closure. And similarly, so you can use continuous interlocking. You can use parachuting stitches. You can use it doesn't matter. What matters the most is supported mucosa, non-cauterized mucosa, good vascularity. You don't lift the esophagus off the tumor, off the bed, so that the prevertebral vascularity goes up. So these are the most important things. Quick points from the panelist. What are all the preferred techniques for you? Dr. Amit, how would you close it? Primary, intermittent, continuous interlocking. What is your preferred?
It's a corner technique. We always use the same thing, like a zipper technique. And the only concept is it should not be strangulated and the mucosa should be inverted. So that's the concept.
Perfect. So now that we have done that, then as Prashant told, always when you make the cut, that time you take a stitch so that the trachea doesn't get down below. So now coming on to the voice process. This is how we were doing it before. Use a pharyngeal protector, identify the identify the party wall, make an incision at least 0.5 to 1 centimeters from the cut end. So then you try to pull it out. This was little cumbersome before. Now with Provox Vega puncture set, this step has become very elegant. So this we all know. This is how we are doing it now. You make a puncture. You have a pharyngeal protector here. You palpate the pharyngeal protector. Then you use a puncture set. Then you pass a guide wire to it, and the guide wire comes out to the puncture set. Then you would have a dilator on. This dilator directly dilates and puts it back. So now with this puncture set, the putting on the TEP becomes much easier and much simpler. So there we close, and final concluding points from the panelists. What's your thoughts on TEP? When would you do a TEP? When would you not do a TEP? And anything else on for the total laryngectomy?
May I add a point?
Yes, sir, please. And we are winding up. This is the last slides. Yeah.
Yes. So the prosthesis insertion was shown here. So as you told, the puncture has to be taken about 0.5 to 1 centimeter, what you mentioned. So we have to be careful that when the voice process is in situ, there should be some mucosa above it, which is available for closure. So that's why the depth, the depth
very
of the
important point.
It is very important.
Yes.
And second point, which probably which could have been added for the younger this thing, that we need to cut the medial end of the sternocleidomastoid to create a
so that you could have a flat stoma. Putting we can put a voice. Yes, hands free becomes easier. Perfect.
That is an important step which I've seen in some post-op patient which gets missed out. So that causes a well formation, and it's very difficult to phonate with that kind of a stoma.
Correct. Perfect.
Thank you.
Dr. Amit, final concluding points regarding voice process, regarding total laryngectomy. What do you want the postgraduates to take home?
Yeah, so one important thing is whenever the subglottis, piriform fossa apex, lower part is involved, always think about levels pre-paratracheal node dissection, because this is the most important, which books actually have not written properly.
Correct.
So that is the one emphasizing point. Other thing is if mucosa is normal, if party wall is normal, always do primary. If you are confused, if you are finding that it's a pale mucosa, it's not pliable, it's better to leave that thing and just do secondary, as in Salve setting, as in doing any augmented or circumferential reconstruction, or you need to be careful that the party wall should be intact. Like in gastric pull-up and all, you need to be careful that party wall is, if it is intact, then only it will work.
Perfect. So take care of stomal recurrence, do a neck dissection in level 6 whenever needed, and take care of the party wall, and do a primary TEP as much as possible. In post-RT settings, be careful in doing a primary TEP. Dr. Vipin, any points for the and we are finding it up on last 2 talks and then last 2 points and we are through. Dr. Vipin, anything you want to add for the...
In 10 seconds, most of the things have been covered. Always a primary TEP if possible. And secondly, I will not put a TEP if we are reconstructing, if we're doing a circumferential reconstruction.
Perfect. No TEP when there is reconstruction. Yes.
Major myocutaneous flap, I will not put a TEP in
primary TEP. Perfect.
Otherwise, my preference is a primary setting.
Perfect. Prashant, last words from you, and then we wind up.
Just 2 simple points. Choose your patient well. Okay, if the patient is compliant, saying it's very easy to use and manage the TEP. But patients who are from rural areas, follow-up is difficult. Sometimes they are better off with the electrolytes. I generally give the option to them. I make them meet my patient and let them decide what they want, whether they want a electrolytes or a TEP. And lastly, I think one important point I'm doing nowadays is LaryTube. That LaryTube soft tube is very nice, especially during radiotherapy, because most patients tend to have stenosis during radiotherapy, and they come to you after radiotherapy with a stenosis, which becomes very difficult to manage. So just these 2 points.
LaryTube solves the problem of stomal stenosis. So LaryTube without fenestra, you use it when you don't have a TEP. LaryTube with fenestra, you use it when the patient is with TEP, so that with that stomal stenosis problem is solved and the phonation gets better.
Okay.
Thanks a lot. Thanks for the panelists for enlightening us. Thank you, Dr. Poonam, and over to you.
Sir, can you please unshare the screen now?
Yes.
So, thank you, sir. I extend my sincere gratitude to our esteemed panel members and moderator for their insightful contributions and for guiding the discussion in such clarity and depth. And now moving to our next session, it's an operative technique discussion on thyroidectomy and central compartment dissection. In our expert panel, we have Dr. Kaustubh Patel, Director and Head, Department of Surgical Oncology, Astha Oncology Associates and HCG Cancer Center, Ahmedabad. Dr. Saurabh Vashni, former Executive Director, AIIMS Patna, Professor and Head, Department of Otorhinolaryngology and Head Neck Surgery, AIIMS Rishikesh. Dr. Ravi Shankar, Senior Consultant, Department of Head Neck Surgical Oncology, Mahavir Cancer Sansthan, Patna. And Dr. Pallavi Kaul, Assistant Professor, Sri Guru Ram Rai Institute of Medical and Health Sciences, Dehradun. And today's speaker of this topic would be Dr. Poonam Joshi, who is a professor at the Department of Head and Neck Surgery at TMC, Tata, Mumbai. And now I would request ma'am to please start the session.
So, good morning to everyone once again. And I thank Kaustubh sir, Saurabh sir, Ravi and Pallavi being here. So this topic of presentation of mine today is operative technique discussion, thyroidectomy and central compartment dissection. So if you look into, like, as we all know, that thyroid masses have been mentioned in the literature throughout the centuries, like 12th and 13th century. And if you look into this picture on the right side, this is basically a surgeon who is treating a patient of thyroid mass with the help of two iron rods, which were actually pushed through the skin and then to the thyroid mass. So this was a long time before, and that time the skin used to get necrosed, and then the thyroid mass would be pulled with the help of a hook. This all led to naturally lot of sepsis, complication, morbidity, and mortality. And thyroid surgery at that time was considered barbaric. Ultimately, it was Theodore Cocker who made thyroidectomy as a safe surgery when the mortality rates got down to 1%. And he got Nobel Prize in 1909. So we know thyroid surgery is performed for benign as well as malignant diseases, and a poorly performed surgery can lead to major morbidities like recurrent laryngeal nerve injury or post-operative hypocalcemia. So surgery can be performed by mainly two approaches, which is conventional and open approach and remote access approaches. So when you look into the open approach, there is conventional open approach and there is minimally invasive video-assisted thyroidectomy, which we can see here as B photograph, and C and D as the lateral approach. So Kaustubh sir, in your practice, do you use, like for the open approach, do you use, other than the conventional open approach, do you ever use the B or CD approach? Sir, you are muted, sir. Hello.
Most of the time, I would go for an open approach, which is a central approach. If it's a revision surgery, it's a recurrent surgery, my approach will be a lateral approach, where I would try and find out the nerve first and then go into the area where there is a recurrent tumor.
Correct. So, Saurabh sir, your views?
See, I'll prefer a central approach. I usually prefer a central approach only, and central approach, if you are talking about the incision, then I will go over a standard collar incision, coccus incision. This is what I prefer.
Correct. So I think most commonly the incision which we used is conventional open approach, and like Kaustubh sir rightly said, in recurrent cases you can use the lateral approach, which is also called as the backdoor approach. So usually the indications for minimally invasive video-assisted thyroidectomy are actually very few, and there are usually it is done for small thyroid nodules. It's not has been very adaptable in many centers across the world and is hardly used, not very much reproducible also, and doesn't have major benefits. Whereas the lateral approach can have the direct access to vital structures and can be used, like sir rightly said, in cases of recurrent lesions where the midline approach has already been tried and there is a lot of fibrosis. So coming to the remote access approaches, this is just for the completion, for the sake of the approach. There are approaches like chest-breast approach. There is bilateral axillo-breast approach, which we fondly call as BABA. Then there is trans-axillary approach, which is C. Retroauricular approach is one of the approach, and trans-oral approach. So coming to the anatomy of thyroid, we all know that thyroid is a bilobed structure, and it usually lies from C5 to T1 vertebra, with the isthmus joining them, lying against the tracheal rings 2 to 4. It is quite vascular, supplied by superior and inferior thyroid arteries and drained by multiple veins. So the position for thyroid surgery is usually a coccus or rose position, where the patient lies in a supine position and the neck is extended. Usually the neck is extended with the help of a donut cushion under the head and a shoulder pillow between the shoulder blades. This causes the extension of the neck. Usually 15 to 30 degrees of reverse Trendelenburg is achieved so as to get the head up position, and this leads to, this helps in minimizing the venous engorgement. So regarding the incision, like how do we plan the incision? So anyone, Kaustubh sir, Saurabh sir, Pallavi or Ravi, where do you exactly plan the incision and what size do you take for a routine, I would say for a routine only total thyroidectomy case?
So, one of the important things is that how I usually plan my incision, that I'll put it around 2 centimeter above from the level of the clavicle, and it usually would be in the most prominent skin groove. Usually, if the patient is bulky, or especially in female patients with large breast bulk, I usually prefer to identify my incision site before shifting the patient to OT in the pre-op area itself. The incision, one of the most important things in deciding the incision, that we should make all possible attempts to make it symmetrical. So usually the incision can extend from anterior border of sternocleidomastoid to the anterior border of sternocleidomastoid. But in smaller tumors or smaller masses, we can just extend the incision between the two paramedian lines from the midline in a symmetrical fashion. Depending upon the size of the lesion, we'll try to make the lesion incision as small as possible.
Excellent points, Ravi.
Okay.
Kaustubh sir, Saurabh sir, any points?
Yeah.
Yes.
Yeah, Poonam, I'd like to add further that whenever we give mark an incision for thyroidectomy, we have to take into consideration the extent of exposure is most important. When you're doing an open approach, your extent of exposure is very important. If you're doing only thyroidectomy or the extent of thyroidectomy, then your incision can be from, say, if you're doing hemithyroidectomy, it can be from the anterior border of the sternocleidomastoid to anterior border of the sternocleidomastoid. If you're addressing the neck also, then you have to have extended coccus incision. And as mentioned in females, beside female, it's a obese patient. If you have a short, thick neck, then also your incision has to be slightly higher. Normally, we measure it with putting 2 fingers over the subpleural notch, and that makes almost 2 centimeter, what was mentioned. But if we have a short, thick neck or an obese patient, in that case, slightly higher incision is taken because we have to have a wider exposure in that, and the length of the incision has to be slightly more horizontal because of the exposure. It is usually recommended, and it's all better, and we also practice that we usually mark the incision, just see the neck anatomy in sitting posture also, because we have to, many times the folds, that the Langerhans lines are not clearly visible in an extended neck when you're marking the incision. So we miss the skin creases, and that is a cosmetic, I think, factor which gives a poor scar in the neck. So we should always put a mark in a sitting posture pre-op without extension of the neck, seeing the Langerhans lines where probably the incision will be, and then finally plan the incision on the tip. Sure.
Great points, sir.
So, Poonam, what you have enumerated are very important points. Only thing which I would like to add is that the size of the incision, you must consider the size of the mass and the size of the thyroid which you are going to remove.
Correct.
You don't want it to be crushed. You want a proper exposure, as Dr. Saurabh told. For the exposure, you need to retract the thyroid. So that's why you need that kind of an incision which will be able to retract the thyroid and will let you go into the TO groove properly. So, and what I usually do is I don't give lot of extension. The reason is that the skin becomes tight and retracting it becomes a little bit of a problem. What I usually at my place do is a window kind of a retraction, meaning that there is a minimal extension of the neck, and the incision and the wound will rotate around the area where I am dissecting. So the retractors will go on taking that window to the area of dissection. But that can occur only if there is not a lot of extension of the neck. So that is one different technique which I use.
So great points, Saurabh sir and Kaustubh sir. I think one point which Kaustubh sir said is size should be defined as per the extent of the resection. That are you doing a hemithyroidectomy, total thyroidectomy, you are doing a neck dissection, and it should depend even like what kind of lesion you are having. It is a large lesion which is having extrathyroidal extension. So many points have to be considered when planning the size of the incision. And moreover, the skin should not be stretched too much just for making it as a small incision. So great point, sir. And another point which I think most of the speakers, the most were included, were that in female, one has to be really careful regarding the site of the incision, because the females, it is appropriate to do it in the sitting posture. So Pallavi, any points you would like to make?
Yes, ma'am. Good morning, ma'am. Ma'am, I think the points regarding incision placement have been comprehensively covered. I'll just summarize it for the interest of students. I think we can classify the incision placement primarily as based on patient factors as well as disease factors. For patient factors, quick summary is that short neck, higher incision, obese neck, a longer incision so that we don't struggle during surgery. Important thing is that if it is a recurrent setting, I think, ma'am, it's important to incorporate the previous scar while placing our incision. So that is one thing I would like to add in patient factors. And then comes the disease factor, which we need to take into consideration. Having said that, if it is a benign disease like goiter and it's a big thyroid, we should not compromise on the size of incision. A nicely placed incision in a cervical crease will give a good cosmetic result. And incision planning, obviously, before taking the patient up for the surgery in the OT, it should be marked while in sitting position as well. A retrosternal goiter, if we are dealing with, or any thyroid disease with retrosternal extension, I would say that we should slightly prefer placing the incision inferiorly, because we know we are going to struggle if the inferior flap is much longer. And in cases of malignancies, again, we have to have a wider exposure. Cosmesis should be given second preference over the oncological clearance.
Great points, Pallavi. So, yes.
Poonam, one more point. I would like to tell the youngsters that don't try to put smaller incisions initially. The reason is that retracting this smaller incision to accommodate the tumor to come out, the exposure, you are injuring the edges of the incision a lot, and that's one of the reason why your post-operative scar will be very bad, because of that issue of lot of unnecessary retraction on the edges of your incision. So, in this picture, you can see that small incision with a hypertrophy. This occurs. So anybody who has also worked in a plastic surgery would realize that handling the edge of your incision during surgery is extremely important. And that is the reason why it is better to put a little longer incision and not to injure your incision edges.
Correct, sir. So I have put a small video. So I think we can build along this so that we can discuss on that point. So this is a video basically of a total thyroidectomy patient, and this was the same photo I had put initially. So here I had taken 2 finger breadth above the sternal notch, and it was in the most prominent transverse crease. So in one leg, saline adrenaline was infiltrated, and we went through the skin. That is the epidermis and dermis, and then going through the subcutaneous fat. So one thing which we have to do is we have to raise the subplatysmal flaps here, and you have to see that the platysma actually drapes the neck from the mandible to the clavicle, but it is deficient in the midline. So when we are raising the flap, initially, like Kaustubh sir said, when you are in the initial part of your training, you can make a buttonhole if you're not careful in the midline. So please follow the platysma from the sides if you're not sure about the plane in the midline. The superior extent is usually up to the lower border of the hyoid, and the inferior border is usually up to the level of sternal notch. So two muscles which usually, the straps which usually come in contact with this with the thyroid gland would be the sternohyoid muscle and the sternothyroid muscle. So what we need to understand is that when we are doing this surgery, we have to understand that the whole neck, the strap muscles, the thyroid gland, they are engulfed in the middle layer of deep cervical fascia, which we also call as the pretracheal fascia. And this does what? This forms a false capsule over the thyroid gland. So when you are doing that, we have to release that false capsule, and we have to stay on the, we have to be in the subcapsular plane, which I am going to show you. So Kaustubh sir, when you treat like the bigger thyroids, do you do the resection of the strap muscles? Where do you do it? Or you do the lateral approach? It's like, what is your approach, sir? How do you access if it is a large, big thyroid?
So my approach is almost always 99% a central approach, however big the thyroid is. And I almost never cut the sternohyoid. Sternohyoid can be elevated well and retracted. Only thing, sternothyroid in a larger thyroid, I always cut. The sternohyoid can be dissected well from hyoid to suprasternal notch so that it can be retracted well laterally, and you can definitely resect the larger tumors. If the tumor is so large that half of it is medial to your sternohyoid and half of the tumor is lateral to your sternohyoid going into the lateral neck, those kind of tumors you might have to resect or cut, I wouldn't say resect, cut the sternohyoid. But this resection can be at a point where, it should be at a point where later on, if you want to join after resecting, if you want to anastomose, yeah, so in that case it should work. So that's why the nerve to strap muscle should be properly preserved.
Sir, great point, sir. So I think the point which Kaustubh sir made here is that most of the time you can get away by preserving the sternohyoid. And sternothyroid, when it is a large goiter, a large thyroid lesion, where it is too extensive and you are not able to pull it laterally or dissect it laterally, in those cases, you can cut the muscle in the higher part, where because the ansa cervicalis nerve, which is the which supplies the strap muscles, enters these muscles in the lower part. So that would be the takeaway. So coming to the next step, so when we are doing this thyroidectomy, this is the lateral extent. What we follow is usually up to the carotid sheath. And this one point which I missed here in this video is that the first point which we'll be doing when doing a thyroidectomy would be ligating the middle thyroid vein, which is not shown here. So once we see here, this is the thyroid gland which is coming into picture. And what we are doing here is we are going in the subcapsular plane, and we are trying to stay in that plane, exposing the thyroid gland. So, Saurabh sir, so at this point, like, how do you follow? So where do you go exactly? So the moment we are on the thyroid gland, do you first go and do the superior lobe? Do you look for the parathyroids? How do you approach the case, sir?
See, we go from medial to lateral, as you have demonstrated that we go from medial to lateral approach, and we first identify the carotid sheath laterally. That's the lateral extent of our dissection. Then we start with ligating the middle thyroid vein so that we release the gland laterally, because this gives us space so that you can dissect further clearly. It gives you more plane. And then we try to identify the superior pole. We start with the superior pole. Then we just dissect it and identify the superior pole first. And then we come to the inferior pole. And before coming to the inferior thyroid, we first try to identify the recurrent laryngeal nerve. And then we go for the last step as the inferior thyroid artery, with the standard we follow like that sequencing.
Okay, so coming to the step, so this is like medial rotation of the gland. And again, we are continuing with the dissection. We are just removing the fascia and exposing the lateral aspect of the gland. So I think two structures which are coming here. This looks like this was the inferior parathyroid. And we still continued our dissection superiorly. And our aim was to first free the upper lobe of the thyroid gland in the subcapsular plane, still continuing with that. So, Ravi, how do you like approach in the superior pole? Do you first look for the external branch of superior nerve, superior laryngeal nerve, or do you ligate the individual branches of the superior thyroid artery, which I had done in this case, because in spite of searching for the nerve, initially I could not find it.
So I'll usually do both the things. I'll hold the superior pole of the thyroid. I'll retract it outwards and inferiorly. I'll do a gentle and careful dissection in the formed triangle over there with the superior pole and the midline and the hyoid. I'll do the dissection in the direction in which usually external branch of superior laryngeal nerve will travel. Mostly will be able to identify external branch of superior laryngeal nerve, but in many cases we may not be able to identify the external branch of superior laryngeal nerve also. If that happens, then I'll individually ligate all the vessels. I'll either ligate or I'll clip the vessels, all the vessels, and then I'll free the superior pole of the thyroid gland, and then I'll continue my dissection.
So Pallavi, do you follow do you look into that Jaws triangle, which we are so fond of asking in exams, or do you follow the cricothyroid space of Reeves, or I did it here because initially I could not find it. You just do the subcapsular ligation, or you don't look at it at all. So how do you go ahead about the external branch of superior laryngeal nerve?
Ma'am, before going to that, I would also want to highlight, because you have beautifully demonstrated in the video which you were playing, couple of points. You started using bipolar. So as soon as we are off the strap muscles, we should have a higher threshold for using less of the thermal instruments. So we should swap from monopolar to bipolar. Very important point, because we have to err on the side of caution, not to injure the vessels, not to cause thermal damage to the adjacent nerves, and most importantly, the external branch of superior laryngeal nerve, which might also have transmitted heat from the use of monopolar if used in this region. Second point, ma'am, I usually like using the medial pocket approach because it is a relatively avascular space. So following that, close ligation to the superior pole of the thyroid gland. That makes the space. If a gland is smaller in size, then it becomes easy to identify depending upon which type of Cernia classification the jaw in the jaw's triangle the nerve is located. Sometimes it is visible. But mostly, ma'am, before retracting the superior pole and dividing the vessels, it becomes hard to identify the nerve. Another important thing is, ma'am, if I have nerve monitor available with me, nerve monitor is an excellent tool for demonstrating that classic twitch. So obviously, if I find the nerve, I would love to demonstrate that twitch and confirm that my nerve is functional. So they are a couple of points. And while ligating, I have switched from over years from suture ligation to ligature, but I still tend to clip the upper end. So the vessels which we are ligating, they should always be, classic teaching was double ligation of the vessel, which is staying in the body, the cut end of the vessel. So we should ensure that they are adequately sealed so as to avoid any hematoma in the post-operative period.
Correct. Yes, sir. Sir, you're muted. Saurabh, sir, you're muted.
Just a minute. Now
Yes.
it's audible?
Yeah, it's audible.
Okay, so see what was said. I'd like to add two more points. Number one, it should be very clear understanding that vessel, that is artery and vein, should not be light together. We should not be tying them together. So they should be dissected separately, because as per the various types of location of external branch of superior laryngeal nerve, in 10 to 15% cases, it is that it comes along with the superior pedicle. So if you're ligating the artery and vein together, there is a possibility 10% times in your case that you may ligate the external branch superior laryngeal nerve in the pedicle if you like. So it is always a standard practice to dissect the artery and vein separate. And as said, because superior pedicle does not have too many branches as the inferior pedicle has. Because if we talk about inferior pedicle, the location and vein and artery, it has multiple branching, but superior pedicle does not have that much branching. So you can very clearly identify the artery, and as rightly mentioned that you have to be as close to the gland. And I fully agree with you, as in this case, it is not always that we find the external branch of superior laryngeal nerve. So you have to take the 90% probability chance that be very methodical in the ligating the pedicle, so that you are away from the external branch of superior, even if you don't see it. That's a standard practice.
Correct. So, yes. So, coming to the next step, so we dissected.
Poonam, something?
Sir, yes, sir. Kaustup, sir, yes, sir.
Yeah. So, this problem of external branch of superior laryngeal nerve is something which we have been taught for years together. And this hernia classification also we understand. But basically we have to understand that it's the nerve doesn't vary. It is the thyroid lobe which varies. If thyroid lobe is enlarged in the higher space, you will find an external branch crossing it. But if thyroid is low down, thyroid is atrophic, there is a small thyroid, the upper lobe will be so down that you may not find it. So that's the reason why we have this problem of few patients getting injured, few patients not getting injured without looking at it. And that's the reason why the neuromonitoring definitely helps in these kind of situations. Any strand going horizontal when you are dissecting the superior lobe, you should not bipolarize without checking it, or at least by magnification, have a loop and see that whether it is a small vessel, small vein, or it's a nerve. So it's important to identify that strand which is horizontally crossing. Now, if it is not crossing, you go to the upper pole and see that whether there are any strands going horizontally, or there are any strand coming vertically and then going into that space of ribs. So that space is important. What I do usually is, when I retract the sternothyroid or cut it, I first identify the anterior branch of superior laryngeal artery, superior thyroid artery. Then try to find out the things which are around it. And as Pallavi rightly said, I would go to that space, which is an avascular space, try to find out things over there, and then go up towards. I would not hurry to go to the upper pole. I would go slowly from down to up and try to identify the structures and then clip whatever structures needs to be clipped, as you have done in your dissection. And if I have a nerve monitor, which I have because I do all the cases now with nerve monitoring, I would like to identify, confirm, and then cut other things.
Correct. So important, great points made, sir. So just to summarize, if you have to look for the external branch of superior laryngeal nerve, it is better to go and first try into the cricothyroid space of Reeves, which is a 8 vesicular space. Open that space, try to search for the nerve, try to search it in the anatomical space. Or if you have IONM, use that. See if any horizontal fiber going that way. Please don't cauterize or ligate it. And then once you are sure about it, ideally, then you should go for the ligation of the superior thyroid vessels. It is always better to do the individual ligation of the tertiary branches if possible. So going ahead with the next part. So this is the photo which I actually liked, and it was so similar to the photo here. So this actually shows us the inferior parathyroid gland, and here is the superior parathyroid gland, which actually is corresponding more or less here. And you can see this is the leash of vessels with the inferior thyroid artery, which is corresponding here. So, sir, in your practice, Ravi, Pallavi, how do you identify the parathyroid glands? And because many a times, because there may be multiple nodes or fibrofatty tissue here, and we can easily get confused in identifying the parathyroid glands. So do you do some procedure? Do you do ICG? Do you have any clinical characteristics? You send it for frozen and identify it. How do you do it? Especially in cases when there are multiple neck nodes. So anyone can take this question.
So, ma'am, usually what I would do that I'll continue doing my capsular dissection. In capsular dissection, usually after dissecting in the superior pole of the thyroid and being very close to the capsule, when I am leaving all the tissues behind, as I approach towards the tubercle of the carandle, I'll see my superior parathyroid lying over there. Similarly, I'll start. So after doing my superior pole, I usually go towards my inferior pole. There, I'll start my dissection in a capsular plane, and then I'll move superiorly towards the mid pole. During that portion, around again moving towards the midpole, I'll be able to identify my parathyroids. I'll use multiple pointers to identify my parathyroid. So I take help of inferior thyroid artery. I take help of tubercle of Zuckerandl, and I take help of the texture and the appearance of the parathyroid gland to help me differentiate it from the lymph nodes. If I have any doubt about it being parathyroid or not, then I'll definitely take help of frozen section also to confirm that this is parathyroid gland, given that its vascularity is not is compromised. If I am sure that inferior thyroid artery is coming, it is supplying both inferior and superior parathyroids, the vascularity is intact. In that case, I will not take help of frozen section. I'll just let it be.
So I think great points made. Pallavi, you would like to add something to it?
Ma'am, I think Dr. Ravi has covered the points. A couple of things which, in addition to what sir has already said, the picture which you showed, ma'am, initially. So, for the interest of students, we have to remember that the superior parathyroid is more so consistent in position, and it's the inferior parathyroid which is more variable. So, the first step, if we are doing especially a total thyroidectomy, we have to keep in mind to preserve as many parathyroids as possible. And by preservation of parathyroid, it's not merely the anatomical integrity of that parathyroid, but also the vascularity. Sometimes we do an excellent job after total thyroidectomy preserving all the four parathyroids, but unfortunately, patient lands up in hypoparathyroidism, primarily because the vascularity is compromised. So small things which I think personally can be done to augment the procedure and to make it more safe is that wearing loops or magnification wherever possible, because that definitely aids. I, over my journey and career of doing thyroidectomy from residency, from a trainee to a mentor now, have realized that magnification definitely makes a difference. Identifying those small feeder branches to the parathyroid makes a difference in surgery. Second thing, try to preserve superior parathyroids, the anatomy which is going to help us always. So try and preserve always the superior parathyroid, because inferior parathyroid, there might be a possibility that we might inadvertently injure the vessel supply of that parathyroid. Then plane relation to, we classically say that there is a recurrent laryngeal nerve plane. So the superior parathyroid lies in a plane which is posterior. So once we have identified that nerve, because my teachers taught me that the first 100 cases in thyroidectomy is about identification of nerve. After that, it is more so about identification of those parathyroids, because that's going to cause a lifelong morbidity. So always look for parathyroid. Superior parathyroid will be in a plane posterior to the nerve, and inferior parathyroid tends to be in a plane more anterior. So more chances of injuring these inferior parathyroid. Ma'am, inadvertently, if I remove a parathyroid and then there is something called as a float test, fat versus a parathyroid. So obviously we can put that specimen into a container containing saline. And if it sinks, it means it might be a parathyroid or a lymph node. Now, if you have a doubt, so then it can always be a portion of that can be sent for frozen and get a confirmation that is it a node or is it a parathyroid gland, and then going ahead with an auto reimplantation of the parathyroid if it turns out to be a parathyroid is mandatory. Apart from that, ICG, ma'am, I have tried using ICG. It's a standard technique which has been mentioned to be more effective in identifying, but I'm not very convinced. Maybe it's a learning curve. I've not been able to use that technique with, demonstrating parathyroid. So I rely primarily on the anatomy. And ma'am, one another point which I've learned, that after removing the gland, we should always inspect for those intrathyroidal parathyroid. After removing the specimen, check for that. If we find any such suspicious thing which is embedded within the capsule of the thyroid gland, we should always remove and send for frozen. And in a benign case, we can always reimplant that inadvertently removed, because we don't like a specimen report coming out and showing that, oh, there is a parathyroid attached to a gland.
Correct. So great points, Ravi and Pallavi.
Yeah.
I think regarding yes, sir. Regarding parathyroid, most of the points have been included. Yes, sir.
Poonam,
Sure.
excellent point. Pallavi summarized very well. The only thing which I would like to, are you able to see? I have drawn an
Yes, sir.
arrow.
You have marked it. Yes, sir.
Yeah, I
That's
have
the
marked an
parathyroid.
arrow. Now,
Yes.
see, my point is that I clip ligate the anterior branch of superior thyroid artery, but the posterior branch I don't. What I do is I try to take a bipolar in my hand and try and bipolarize all the vessels going down to the thyroid. In that way, this superior thyroid arteries branches lead me to the superior parathyroid sometimes. And that is the reason why I don't ligate the posterior branch. What I do is then I move down into the lateral part where I find out a Zucker candle. But before going to Zucker candle, I see to it that there is no fat or looking like a fat kind of a structure over the thyroid. So my dissection preserves all the fat like looking structures which are on the thyroid. When my specimen comes out, there is no fat on the specimen. So that is what is very important, so that you are not inadvertently damaging the blood supply or parathyroid. So that is the way I would like to go and arrive at this point, rather than not doing this dissection, clipping the superior thyroid and coming on the lateral side.
Correct.
That is one point I do a little differently. The second thing is that we usually have a fluorescence imaging. So whenever there is a doubt, we would do a fluorescence. We will not give IRILIC, we will not give ICG, but we will ask the OT lights to be off. We just have a handheld camera and we can see whether whatever structure is there is fluorescent or not. If it is fluorescent, it has to be parathyroid. So that is the way, that is one more thing by which you can identify your parathyroid. The dye is given to see the vascularity, whether the vascularity is preserved or not. But fortunately, parathyroid has autofluorescence. So you don't need the dye to be injected to identify whether it is parathyroid or not.
Correct, sir. So I think all the important points have been already summed up.
Poonam,
Yes, sir.
Poonam, I'd like to, just because parathyroid, as was mentioned, is a very important structure to be preserved in thyroidectomy. One anatomical landmark I like to add on is that the inferior thyroid artery recurrent laryngeal nerve, where they cross each other, 2 centimeter area above this bifurcate, this say meeting point, is where you look for the parathyroid. It's usually 1 centimeter, but within 2 centimeter you find the parathyroid. That is for the residents I'm telling this. And secondly, your question was very pertinent, that how to differentiate a parathyroid, lymph node, or other structures when you are looking for a parathyroid. So I like to make a point here. The parathyroid usually looks soft and yellow or tan color. It's well defined. It's an oval structure, well defined. While a lymph node, although maybe solitary, it's firm and gray. Lymph node will not be looking like the color as being shown in your videos, very classical parathyroid picture. Fat will always be lobulated and will be regular, because many times we confuse the fat with the parathyroid. So fat will be irregular and will be lobulated. So if you see a structure like that, it should not be confused with a parathyroid. And as mentioned, then we have a fluorescent or we have a frozen section, as there is the last doubt clarification if for the parathyroid. Sure.
Correct, sir. So I think because parathyroid is actually a difficult topic, many a times we all get confused, and I think we have so many important points from the experts that how do we identify and how do we preserve the parathyroid. So in view of limited time, I would request all of you to give your comments that how do you save the recurrent laryngeal nerve, or how do you identify the recurrent laryngeal nerve? Saurabh sir, Vashne sir, Ravi and Pandit.
Okay. In my practice, I follow the landmark as inferior thyroid artery as the main landmark, and tracheoesophageal groove. These two. First, I will say tracheoesophageal groove, that we try to look for the nerve in the tracheoesophageal groove. And second landmark, we correlate with the inferior thyroid artery. These are two landmarks if you want to know about it. Sure.
Kaustubh sir, how do you do that?
Yeah, so in my initial practice, I used to go to the tracheoesophageal groove, identify the recurrent laryngeal nerve, try to dissect it to the cricothyroid joint. Up to that level, I used to delineate the nerve and then remove the thyroid lobe. Over a period, I have realized that it used to jeopardize the blood supply to my parathyroids patient were having hypopara on a greater extent. Over a period, I have realized that you try to identify the nerve at one point and try to dissect the nerve as less as possible. Once you have an idea from where the nerve is going where, you can definitely remove it without going down into the tracheoesophageal groove. So my usual today's time, what I do is right now is something which I would not like all the trainee to venture into. It comes at a later date when you have an experience of doing, say, 100 thyroids or 50 thyroids. So what I usually do is, as I said, all the fibrofatty tissue, everything is, brought down from the thyroid capsule. Thyroid is retracted medially. I go to Zucker candle. That is the area where I would like to find out the recurrent laryngeal. Now, once it is found out, at that time, when I try to bipolarize all the branches of inferior thyroid artery going to the thyroid, I see that the nerve is protected well. I have a neuromonitoring in all cases, so it identifies the nerve at that region, and then retracted laterally, I would try to remove the entire thyroid lobe.
So I think great points. Anything else, Ravi or Pallavi, you would like to add? Because we are short of time, and that's why I'm running the video as well. So any other point, Ravi, you would like to make? How do you
Ma'am, sir
identify the
has,
recurrent laryngeal nerve?
I think, ma'am, sir has explained and summarized it beautifully. I also identify the nerve usually at the tubercle of Zuckerandel, as it lies usually dorsal to tubercle of Zuckerandel. And it also gives us the benefit of doing minimal dissection for the nerve with this surety of identifying and be sure that the structural integrity of the nerve is intact, is present. Only some things which we have to be aware of is that in larger thyroids, if tubercle of Zucker candle grows in size, then at times it can grow dorsal to the or behind the recurrent laryngeal nerve. So we have to be aware of this information doing this dissection. And in these scenarios, it is prudent to identify it at a lower level. We can use multiple landmarks for identifying the recurrent laryngeal nerve at a lower level. We can use TO groove, we can use inferior thyroid artery to identify the recurrent laryngeal nerve. But the whole idea is the same, that identify, do minimal dissection, give a complete clearance of the thyroid gland, and ensure that the nerve is intact structurally.
Correct. So I think all the important points made. I think it is actually association of multiple factors when we identify the recurrent laryngeal nerve, like the position, like the assessment of the
Poonam, one
Yes.
important point. I'm sorry, I'm interrupting, but when we close the recurrent laryngeal nerve discussion, we must mention the non-recurrent recurrent laryngeal nerve. And the most important way to identify non-recurrent recurrent laryngeal nerve is by preoperative CT scan. If you find an aberrant right subclavian, that patient has a non-recurrent recurrent laryngeal nerve, and you must do, at least your sonographist must be able to tell you, or the CT scan must be able to show you that aberrant subclavian. And there you must expect that this patient will have a non-recurrent recurrent laryngeal nerve, and that will save the nerve for that patient.
So, sir, thank you so much. I think because of we have already been ahead of time, and so thank you. I think great points. Only one important point when a student starts the thyroid surgery. One point from everyone, starting with Kaustubh sir to Saurabh sir to Ravi and Pallavi. One important point.
Put adequate incision. Exposure is extremely important when you are starting thyroid surgery.
I like to say that it is very important to identify the recurrent laryngeal nerve, as was being told by Professor Kaustubh, also for the beginners. And you should not ligate the inferior thyroid artery any branch before identify the recurrent laryngeal nerve. So that should be for the initial steps. It should be, and second is that don't rely on one landmark for identify recurrent laryngeal nerve. Many times one landmark will not lead you straight away, so you have to know 2-3 positions where you can find out the recurrent laryngeal nerve.
One point which I would like to add, ma'am, is regarding flap elevation. I have seen a lot of trainee students doing buttonholing while doing flap elevation. So one thing which we can do while elevating the flap is that we keep the direction of cautery parallel to the skin and muscle being elevated and not perpendicular to it. It is a very common mistake, and if we take control care of this, the buttonholing will always be up. We will never have buttonholing of the skin.
Great point. Pallavi?
Ma'am, sound knowledge of anatomy and patients during surgery. I think they are the key for thyroid surgery. That's it.
So I thank all the esteemed panelists. Sorry, I had to rush it a bit because of the limited time. And thank you so much. I could not cover the central compartment part. And I thank you once again for your great insight and inputs. Thank you, sir. And thank you, both of you. And thank you, Pallavi and Ravi.
Thank you, ma'am.
Thank
Thank
you,
you,
Poonam. It
Professor
was a
Poonam.
very
Thank you.
interesting discussion.
Thank you,
Thank
sir.
And valuable inputs. Now, moving forward with our next discussion would be a panel discussion on robotic surgery for head and neck cancers, need or hype. And in the expert panel, we have Dr. Shivakumar Tyagarajan, who is a professor in the Department of Head and Neck Surgical Oncology, Tata Memorial Hospital, Mumbai. We have Dr. Siddharth Shah, consultant head and neck and skull-base surgeon, Zydus Hospital, Ahmedabad. Dr. Abhishek Bhardwaj, Associate Professor, Department of Otorhinolaryngology and Head and Neck Surgery, AIMS Rishikesh, Uttarakhand. And Dr. Anthony Raj James, who is an Assistant Professor in the Department of Head and Neck Surgical Oncology at TMC, Navi Mumbai. The speaker for this session would be Dr. Rakesh Katna, who is a Senior Consultant in the Department of Head and Neck Surgical Oncology, Bombay Hospital, Mumbai. So I would request Dr. Rakesh Karna to please share the screen.
Yeah, hello. Hello, good morning.
Good morning, Rakesh. Hi, good morning.
Yeah. Can you just open, and enable my video because that is one there. I am sharing my screen in the meantime. Yeah. Okay, is the screen visible?
Yes, we can see it, Rakesh.
Yeah. So again, thank you very much, Poonam and the rest of the team. A very good afternoon to all of you. And I'll welcome my panelists, Dr. Shiva, Dr. Siddharth, Dr. Abhishek, and Dr. Anthony James. So with respect of time, that we'll just start our session immediately. I've tried to keep it a little more interactive and no videos here, but some panel discussions, some pictures only. So what we are discussing today is the role of robotics in head and neck. So the main topics which we'll be covering is transoral robotic surgery, the TORS, which is the main indication for robotics in head and neck. Then we'll go on to robotic thyroid and robotic neck dissection, plus emerging roles in carcinoma, unknown primary, nasopharyngeal carcinoma, and a little bit on parapharyngeal space tumors. So we all know that robotic surgery, especially transoral, has given us another armamentarium, another one of the management tools for oropharyngeal tumors, especially, and the supraglottic and limited hypopharyngeal tumors, where we can improve the functional outcomes, especially in the early tumor settings. Similarly, robotic thyroidectomy with its very well confirmed cosmetic advantage now. There's a lot of data which has emerged in last few decades, which without compromising any surgical safety. So that we'll be discussing. And plus, so robotic neck dissection, which is, I'll say, innovation ahead of its time, but it's gaining popularity, especially in squamous cell carcinoma also. That also we'll briefly discuss. So the key points here are to identify first that whether what should be the patient selection criteria, that who benefits from the robotic approach as compared to vis-a-vis open surgery, and then to compare the effectiveness, whether the robotic access or the robotic approach is coming up against the standard approach or not, like TORS outcomes are against radiation or chemoradiation for oropharyngeal or supraglottic tumors. Similarly, the BABA approach, transoral robotic or axillary robotic thyroidectomies against the conventional thyroidectomy, how do they fare? That we'll discuss. And we'll look at the barriers also to adoption, like training, the cost, the infrastructure challenges in different healthcare setups, which we all are working. Yeah, so I'll start with the first, the TORS. Let us presume, let us start with this case discussion. This 58-year-old gentleman, it came with an ulcer. We not very commonly we see small lesion in the left side of tonsillar area, 2 by 2 centimeter ulcerative lesion, left tonsil extending from anterior pillar to the posterior pillar. And this is the scan of the patient. So, which is a T2 hyperintense heterogeneous lesion involving only minimal involvement into the lateral base of the tongue and mainly extending into the tonsil pillar without any lymph node. So, Shiva, are you there? Yeah. Hello? Hello? Dr. Shiva, Dr. Anthony?
Yes, sir, I'm here, sir.
Yeah. So any of the panelists, so what are the treatment options? Would you send this patient for radiation, or you'll consider a robotic approach or robotic access for this patient?
Sir, before we decide that, I would like to see whether the patient mouth opening is good. Is he actively chewing tobacco? How is there any oral submucous fibrosis? And most importantly, if this tonsillar lesion is extending into the base of tongue, and if there is concomitant nodes also present.
Yeah.
Suppose if nodes are present, in the event I have a level 2 node, then if I do a transoral robotic surgery, anyways the patient is going to go for an RT.
Right.
So we are making it into a bimodality treatment.
Yeah.
So if the patient is N plus, then I will think of radiation. But of course, if the patient is having a good mouth opening, he's willing for surgery, and also we tell him that if nodes come positive, we'll send you for RT, and he's okay with it. Then we might as well plan him for transoral robotic surgery, sir. This is a very ideal case for transoral robotic surgery.
Yeah. So very well summed up, Dr. Anthony. Any Dr. Abhishek or Dr. Siddharth?
Yeah, as you have already mentioned that the patient is N0.
Yeah, this patient is N0. Yeah, but I think Anthony covered up very well that
Yes,
it's a plus that you have to tell the patient in advance, or otherwise
Right.
you can send this patient directly to radiation also. Yeah.
Right. And also the counseling of the patient is important, right? Many times we take up the patient for TORS, and depending on the margins, how is the margins coming up in the post-op HP, right? The patient might require a post-op radiotherapy. So that has to be counseled to the patient before we take up the patient for TORS.
Okay. Dr. Siddharth, you're there?
Yeah. Rakesh,
Yeah,
morning.
Siddharth. Hi, good morning. Yeah.
Yeah, so I think both of them, my colleagues have rightly pointed out. My concern is like, yes, will I be requiring post-operative adjuvant radiation? Considering the radiological findings, a more infiltrative lesions probably will make me think more in favor of post-operative adjuvant radiation. A
Correct.
more proliferative will be my choice of patient would be taken for TORS. Considering all the parameters, feasibility of the TORS resection.
Yeah.
So a discussion of a post-operative need of adjuvant radiation has to be very clearly done at the onset of the plan. Provided available as a resources, TORS would be a better option over sending this patient for radiation.
Yeah. So
So Rakesh,
let us.
sorry to,
Yeah.
Dr. Shiva has also joined. Yeah, because he
Okay.
joined the.
Yeah. Welcome, Shiva. Hi. So, Shiva, we're just discussing a T1 borderline, T1N0 tonsil. So, options for radiation versus this is a de novo case. Now, all the panelists have given this opinion, but if we look at the data of orator 1, orator 2, Shiva, are you there?
Yeah, I'm there, Rakesh. Yeah.
Yeah. So, it's a de novo oropharyngeal T1 borderline T2N0. But if you look at the data which is generated, the randomized trial, orator 1 and orator 2, it's not very strongly in favor of doing a TORS versus radiation therapy. What's your opinion on that? Yeah.
So, is this patient P16 positive or negative?
This patient is P16 negative. As majority of our patient in Indian subcontinent would be P16 negative.
Yeah. So, for P16 negative, I think we cannot be, dogmatic about what will be better because both the trials have are P16 heavy, for P16 positive mostly, and a few P16 negative. So we all know that in T1 N0, I mean, there has to be a discussion with the patient. If we can, since it's a P16 negative, of course, adjuvant might be needed most of the times. So we need to study the scans well and have the discussion with the patient. And the best situation will be when we can avoid multimodality if possible. But if there's a strong possibility of a tri-modality treatment, that's when, I would think in terms, at least make it bi-modality in the form of, surgery for the adjuvant, if at all, or try to restrict it to adjuvant, just surgery alone is possible. So we need to read the scans well, discuss the options with the patient, the age, comorbidity, various other things will come into, to the discussion. And so we have to take that we have to make that informed decision making with the patient.
Okay. So, Siddharth, if we are considering this patient for TORS, so what exactly complications or the problems you are looking at which you want to avoid on table bed when we are taking the patient for the TORS? What is there in your mind that this might happen? Hello?
I'm sorry. Yeah,
Yes.
so most importantly, what is important is the exposure. We should be able to completely expose the lesion all around, and we should be able to see the margins of our resection. So complete exposure, if I'm not able to achieve with my instruments, probably it's not a ideal case for me doing this TORS. So the retractors, the special blades that have been devised should be there to perform this, because compromising using alternate sources probably might compromise your deeper margins. So that is my first important consideration, that if I'm taking for TORS, I should have an adequate exposure of the entire lesion with the margins that I'm going to take. So this is the first. Secondly, study the radiology very well, so that you know how deep you are supposed to go and what are your deeper vessels. Margins as a vessels is a margin. And to prevent any injury to the major vessels in the deeper plane. So what will be my deepest soft tissue margin, and how the vessels are related to it, so as to prevent any bleeding related to it. uh, Thirdly, there are thoughts like you may take the vessel control in the neck by opening a small cut and taking a hold of the external carotid vessel, so that in the event of bleeding from the major vessel, you can take a control on the bleeding. These are the major
But we'll be doing a neck dissection, so we can always take in a lingual artery in this patient.
as a control. Yeah.
Yeah. Okay, so very important point over here. The most common complications, if we look back at our orator trial also, so orator 2, which was halted because two grade 5 events, as we know, because the death because of the post bleeding which had happened. So that is the most dreaded complication in TOS generally. So that to prevent that, then you have to take your lingual artery. So now let's go back. So we are looking at de novo per primum. My question to all the panelists now, the lot of data which we have seen is all based on HPV positive Western data. HPV negative is very less. But when you look at Winpleri's data and other thing also, they have seen T1, T2, N0. And if there is no need of radiation, then thus the quality of life is much better. So should be an indication for TORS be increased in case of HPV negative T1, T2, N0 oropharyngeal cancers? What is your take on that?
Agree. I
Yeah.
think this is going to be a less morbid in terms of long-term outcomes, as we see with post-radiation, the mucositis as well as the xerostomia that we have, and we at the times also see that a lot of patients end up undergoing a salvage resection post-radiation
Right.
because of the failures. So definitely, if we are able to achieve adequate exposure, adequate margins, we should be aiming to do this upfront as a TORS over radiation in early lesions.
Yeah, Shiva or Dr. Abhishek, any opinion? Yeah, Shiva.
I think for HPV negative, we really don't have strong data to suggest.
Yeah, but we
De-escalation
know the
of
HPV negative is going to be more
Exactly.
RT resistant also.
That's what I'm saying. I'm just coming there.
Yeah.
So, HPV negative, the general discussion is should we escalate treatment rather than talking about de-escalate. So we don't have data for that. So most of the time, I think we should, the discussion again has to be like what Siddharth was mentioning about the exposure, the resectability, the relation to the vessels, whether we can get an R0 resection, and also the expertise of doing this procedure. So that is also very, very important. Occasional procedure being done probably will compromise the result. So we have to, train ourselves to be, to be good at it. And when all of this is available, yes, I think TORS is one of the treatment options that should always be discussed with the patient. And also the discussion of the orator too being stopped. I think the issue, there are multiple issues why it was stopped. And people always, jump on the occasion of putting orator that it was stopped, and the question of TORS being a safe procedure or not is always being said. But then the pathos trial and the epoxy trial clearly showed the safety of the procedure. And the percentage of grade 5 event in these two patients, number of patients both put together was 1,500, and then orator 2 was close to like 62 patients. And they had two patients of death. And in this, both the trials put together in 1,500 patients, the number of deaths were, hardly a couple. Or in pathos, probably none. I'm not sure about that.
Yeah.
But that's what I recollect. So I think the safety is definitely there, but I think we have to apply it carefully in choose identify the right patient, have the discussion with the patients, and then go ahead.
Yeah, so very well put in the points. So we know there's a lot of review and meta-analysis available. There is a lot of other data other than orator 1 and orator 2. So we cannot just extrapolate everything on those two with a very small sample size actually in those two trials. So we have the safeties there. But yes, if you look at the large meta-analysis over here, a lot of patients, they undergo otherwise for RT-CT, RT like 60%. So you should have these discussions with the patient upfront that after TORS. So TORS is also one of the options which you can offer to the patients in a very selective T1, T2 oropharyngeal or supraglottic or hypopharyngeal tumors. But the indication for radiation and chemo-RT, depending upon the histopathology, can happen. So in that patient also, we did the same. It came out to be T1, N0, and we just observed the patient. It's been more than 3 years and patient is doing good. And now next point regarding the unknown primary. So what is the role of the biopsies or the mucosectomies of base tongue? Any one of you would like to answer that?
I think the role of mucosectomy, is being pushed more and more from the Western literature again.
Basically, UK, yeah. UK,
and it's also driven by HPV positive malignancies.
Right.
Whereas, in the South, in our Indian population, it's predominantly HPV negative. And, and the data also, there's a very small series of 48 odd patients by Dr. Rajesh Mistry and his group, wherein they said that when the patient is HPV negative in mucosectomy, there's hardly any primary that is identified after
Right.
mucosectomy. Of course,
Right.
but there are systematic reviews supporting for it, and UK have come out with guidelines that every CUP patient should undergo a mucosectomy. I don't think so.
Mucosectomy. Right.
We have enough data in the Indian context to have anything as certain as that. And even their data is not backed by randomized evidence; it's a systematic review of retrospective, prospective series.
Yeah. Yeah. Anthony, you want to add something? Yeah.
Sir, right now the use of tongue-based mucosectomy in India is questionable, sir, because of the decreased prevalence of HPV, as sir rightly pointed out. But
Yeah.
where we can use it is, sir, like we have exhausted all our options. Like we have biopsied nasopharynx, piriform apex, post-cricoid region. Still, we are not able to find the primary. Of course, as literature says, the primary could have disappeared. But still, if we are looking for the primary as a last line resort, we can use tongue-based mucosectomy to actually rule out that that is the primary site for the CUP, sir.
Yeah. So, the unknown primary, the role is like when the PET is negative, you have all pan endoscopy negative. But generally, it is seen, especially in HPV positive, as Dr. Shiva and Anthony very well pointed out, that Indian subcontinent HPV positivity rates is so low. But yes, at the last resort, you can use, but in UK and other data, they are using it like regularly in their workup of unknown primary. So TORS indication today, if we look at it, Siddharth, you want to summarize when you are making indications for you, those patients are suitable, or what will be the indications for doing a TORS for you today when the patient comes in the
I
clinic?
think it has a lot of variation in the regional also, like in Western India as well as in the Northern India.
Right.
Here, what we get is more of chewers, tobacco chewers. So, though we are limited by the mouth opening that we get because of the submucous fibrosis, so not
Yeah,
many
so that's a
patients.
big no-no that those patients will not fit into it.
Absolutely not fit for
Yeah.
them. So more of us at the same time they come as more of an advanced, locally advanced lesions, which are not amenable for upfront TORS. So they go for at the most a salvage TORS if at all the mouth opening is sufficient enough post radiation.
Correct.
So what majorly we see is more of a salvage TORS rather than upfront base tongue tonsil or a soft palate malignancy that we in my practice that I see.
Yeah.
So I think we have a very limited set of select group of patients that can be afforded or maybe given the option of TORS in our scenario.
Yeah. So generally, to summarize, I put in like post-radiation oropharyngeal base tongue tonsillar region, which have not after radiation, it is salvage resection is there. Sometimes we get small tumors in base tongue or the oropharynx, which is histologies, salivary gland tumors or other
Yes, that
histologies.
is one thing.
So
Yeah.
that is a very, very good point. Means it's a very good modality to do that where we know the radiation is not going to help them. An unknown primary, as we discussed, very limited role in Indian subcontinent. Yeah. It is selective T1, T2, N0, oropharynx, supraglottic, and the hypopharyngeal. And patient young who doesn't wish to take treatment, if it falls into these categories, that can be offered. So as we discussed, the pathos and ECOG, they told that it is very well tolerated, safe, and with N0 status, it can be done. De-escalation, yeah, we are still awaiting for some of the results from the pathos also, whether 50 gray post RT or 60 gray. So that I have not covered much over here, but we'll get some more evidence in the next coming few years. So coming on to the thyroid, Siddharth, let's start with you. You have already done a lot. So cosmesis alone is the indication. Now we are talking about Bethesda grade 4 and above only. We are not talking about the benign patients here, more basically the oncology, the differentiated thyroid cancers. So is the cosmesis alone indication, or you are offering to patients or to all patients low risk, or what are your indications for offering a patient trans robotic thyroidectomy?
Okay, so we are in a forum where more of PGs are there.
Yeah.
So first
So
of
you
all, I
just
would say.
enumerate like indications for them. Yeah.
So yeah, for that interest, I would say we should not be offering this where we are suspecting malignant lesions. So this is more reserved for like any remote access thyroid surgery. As a beginner, should be more reserved for more benign conditions or more favoring towards benign lesions. And of course, cosmos is the only probably the factor that would be the selling point for this remote access thyroid surgeries. Safety wise, it cannot be said it is much safer than open surgeries, because it is, I could say that it is equivalent to open surgery but not better. And For those patients where probably we are with experience going towards Bethesda 4 or 5, we have to select our patients which does not have a extensive kind of, or maybe an extrathyroidal extension or lateral neck nodes, or which requires a extensive nodal dissection. So pure intrathyroidal, low profile or a low volume early thyroid DTCs can be offered for the reason of cosmesis.
Okay. Dr. Anthony or Abhishek or Shiva? Shiva,
Yeah,
I'll
I
come to
will
you
say
later.
that
I'll come for the malignant. Let Abhishek speak. Yeah, please.
yeah, for robotic thyroid, I'll prefer in terms of oncology low risk group patients, right?
Okay. Low
And
risk
as
means
a
what?
beginner,
Whether you are going to do a total or a hemi, or what is the plan?
both can be done, right?
Right.
But see, it has to be counseled. If you are taking T1, T2 patients, which are located only in the one lobe, then we have to counsel to the patient that, okay, if we are going for hemithyroidectomy, there is a possibility of a completion thyroidectomy depending on the report.
Yeah.
So if the patient is willing for a total thyroidectomy in one go, that can be done. Right, so that is a feasible option. If we compare the safety of the surgery, it is equivalent to the open surgery, and I will even say that the vision that the scope provides is quite superior to even your loops or microscope. So there is definitely advantage of vision. Also, the robotic system has got the facility of ICG.
Yeah.
So the parathyroid preservation is also the facility is there, right? So there is a learning curve obviously, but that has a superior advantage over this.
So coming to that ICG, Siddharth or Shiva, any one of you can take it. Are you using ICG for identification of parathyroids in your robotic thyroidectomies or no?
Not for me. I'm not using it.
Okay. Any
No,
specific reason?
not.
Yeah.
Yeah, okay, let's see that please.
No, I'm just not using it because honestly, not very much of my robot thyroids remote access are robotic. So my laparoscopic system doesn't have an ICG system incorporated. So that is why the very few robotic thyroids that I have done, but I haven't used ICG yet.
Yeah. But even the vision which provides and the 4K vision, what you get is
Excellent.
it's very excellent. So it's
Excellent.
like
It's
you
an
can
excellent.
identify with good vascularity, and you know the status after
Yes.
surgery also,
So
whether it's a
maybe one
vascular or
way,
not. Yeah.
since probably at the end, probably if you can see the color of the parathyroids and confirm that they are naturally colored and there is no duskiness or devascularization evidence, probably that is why probably I have not been using it.
Okay. Yeah. So let us start with the case scenario. So she is 43-year-old female, came with the swelling in the right side neck.
Rakesh, Shiva wanted to make a point
Yeah,
on this.
Shiva. Yeah, please go ahead. Yeah.
No, I kind of agree with what's been said, and actually I'm not using it regularly, but where it can be used is to ascertain that whatever parathyroid is saved at the end is
Yeah.
still, having the vascularity or not. So it can just give you that, you can ascertain that it is vascular. But
Vascular at the end of the
yeah,
procedure. Yeah. Then it's very
that's the
helpful.
advantage. And just to add, I think robotic thyroidectomy has an advantage. Okay, the vision, everything is good, but the only advantage robotic thyroidectomy has as of today is in terms of cosmetic benefit.
Yeah.
The rest of it, I think, is quite debatable.
Yeah. Okay. Let's just see this case scenario. 43-year-old female with swelling in the right side of neck from 3 months, 2 by 2 centimeter nodule. Sonography is showing 2.2 into 2.1 by 1.2 centimeter. Bethesda 5 thyroid function test normal. So it is like Bethesda 5. So would you recommend this patient a robotic thyroidectomy or not? Is this patient fits into the criteria of offering?
So, hyperdense solid nodule on the right side. We need to confirm whether this patient would, though ultrasound wise okay, but we still need to confirm whether this patient will need. It's a multifocal disease or not. So
Yeah.
we'll just.
So the other nodule was negative on FNA.
Okay. So now the question is, considering Bethesda 5, there are no neck nodes. Definitely, I would be giving patient an option of remote access thyroid surgery, because I'm not going to address, I don't need to address the neck in this case. So
Correct.
there is definitely an option that can be given to this patient for a remote access thyroid surgery, whatever approach it can be. But yes.
Yeah. Anthony, any or Abhishek, you want to add something? Yeah.
Yes, the patient can be taken up after discussing the option with the patient.
Yeah. Shiva, you want to add something to this? Now, this patient more likely has a differentiated thyroid cancer only, Bethesda 5. Yeah.
Yeah, so we can give the option, of course, but first option of mine would be a conventional open. The second would be remote access. And I would counsel, if I'm also going for an open, I would counsel for a total thyroidectomy for this patient, because so that, you know, even because of the risk of the contralateral node, though it is hyperdense solid nodule, if depending on the approach, if it is a transoral robotic approach that you do, then both the lobes are visualized. You can be safe for the patient. Do a one surgery at the first go.
First go only. Okay.
You can save all the structures, and that's the end of the treatment. Anything needed is only adjuvant. So I would look at it that way.
Yeah. So we did a right hemithyroidectomy for this patient. Here we can identify all parathyroids, nerve, superior laryngeal nerve, and the final report came out to be 1.6 by 1.4, 1.2 centimeter follicular variant, less than 2 foci of capsule invasion, no vascular, no extrathyroidal, no other bad features. So the patient was under hemi only, so she is under control. The cosmetic results are excellent, as we see. There's a lot of data on thyroidectomy for differentiated thyroid cancers also, which has come up apart from benign. But as and there is no, it's oncologically safe and comparable to open surgeries, but again, T1, T2 differentiated thyroid cancers. So again, as Dr. Siddharth and Shiva has pointed out again, that it is a safe, but for students, it's must that initially it must be done only for benign thyroid nodules or Bethesda grade 3, grade 4, whenever you are opting for surgery, and very limited for differentiated thyroid cancer, especially until unless you are a high volume center which is doing even the central compartment neck dissection with a robotic approach. Anything you want regarding the clearance and the lymph node? Are you doing any lymph node clearance, Shiva, central compartment or the lateral compartment?
Only central compartment, not lateral.
Central compartment. Anybody else? Dr. Abhishek, Siddharth, or
Not
anybody?
doing as a prophylactic central compartment, but I'll definitely do an inspection of the central compartment. And if I find any abnormal enlarged node, I would send it for frozen. And if that is positive, I'll do a complete clearance.
So how difficult or how different you find it from doing from conventional open thyroidectomy vis-a-vis versus doing a robotic approach for the inspection of the central compartment and the clearance, if required?
Yeah, if required, I think the only difference probably as compared to open is here, you will not have any traction, especially when I'm not doing robotic traction, or maybe retraction on the trachea, so that you can get a wider space for dissection. So that is one thing. Otherwise, probably it becomes more easier to do under robotic or maybe remote access, because
Yeah,
the
because you're using third arm for the traction.
yes,
Yeah.
yes.
Okay.
So the visualization of the structures, the vital organs, the parathyroids and nerves are very good, and it is easier to go even in the root, I mean as down, so that you can clear up to innominate.
Yeah.
Under
Anything?
vision.
Yeah. Anything, Shiva, you want to add or yeah?
If we are using the infraclavicular approaches, right, there
Yeah,
is we can do the neck dissections quite comfortably, yes. But if there is an obvious lateral neck node, right, or if there is an obvious central compartment neck node, there is a better option of going upfront open rather than going robotic. But if we find during robotic surgery that the patient may require a central compartment, there is no difficulty in it. Only problem is I think the time. The operative time is a concern, right? That increases significantly as we compare it with the open approach.
Yeah.
Yeah.
So
The
if
other thing is, I mean, there's a learning curve, right? And the surgeon has to be cognizant of that as well while offering whichever. I mean, you want to do a
Should-
central compartment, or
Yeah.
with a robot, minimally invasive or a conventional approach, that also should be factored in at the end of.
Yeah. So you do have any number like in your mind for surgeries that a person or a trainee should undergo this much of surgeries for a learning curve?
I remember
Shiva?
Kimte, saying for torque, he was mentioning a number close to 50, if I'm right.
Right.
So I think that for torque, I wouldn't be sure to say this for anything, any other approach. But this is what he was saying.
Yeah.
So I think
I
it
think
needs some, yeah.
Yeah, most important is the creating the access only. So here again, like last talk also we did Dr. Kaustubh, Dr. Poonam, everybody discussing that access is the most important. So here also when you're raising the flap and reaching the thyroid gland, that is most important. So that's what require the maximum learning curve rather than the main surgery itself. Siddharth, you want to
So
add
regarding
something?
learning, I'd
Yeah.
just like to add one point that
Yeah,
for
Abhishek.
residents, it's important to, if you have the facility of simulation, right, invest time on simulation exercises, right? Don't try to just jump onto the surgical part, right? So if the simulation has been done properly, I will say that at least 50 to 75 hours of simulation exercises is important before venturing into the surgical part.
Yeah. So we have ample of data, especially from the Korean side, but lot of meta-analysis, lot of prospective series also, which says that it is as good. There's no difference in the complication rates and the safety, and it's oncologically safe also when we talk about our lymph node retrieval, completeness of the resection. That is when we see the thyroglobulin, the radiation uptake later. But again, you should have we should be very well versed with the open surgeries first. When required to convert it to open, then you can easily manage that. And then you have a learning curve, which is minimum 25 to 50 cases in various publications, but generally that much it takes to this thing. So, Siddharth, you want to, or anybody who wants to just summarize that where will you use robotic thyroidectomy, or which patients you will offer for the trainees? Then we'll go on to the neck dissection part next.
So, in the early process of entering into robotic remote access thyroid surgeries, the benign thyroid nodules are the best to start.
Yeah.
To begin with, ischemic nodules are the best ones or a safer ones to for the learning part, because you will have the flap elevation part, and the ischemic nodules are easiest to handle because you will be preserving the nerves as well as the parathyroids.
Perfect.
The mid pole or the lower pole nodules up to 3 centimeters are the good ones to plan for your earlier cases. The build of the patient is also important. You should not be taking very thick neck or a short neck or a
Obese
very thin
patients.
or obese patient, so that you don't kind of compromise on the flap elevation and all. And of course you should have assisted or got some simulation training of handling the flaps or maybe raising the flaps before you actually venture into it. So a lot of observership or maybe somewhere mentorship is required before you venture your first case.
Yeah. Shiva, you want to add anything? I was just
Yeah.
asking one question to you. Are you using IONM nerve monitoring routinely for your robotic thyroids or
Yes.
no?
Yes,
Yes,
we do.
yes.
Yeah. So that can be used. So it's a intermittent nerve monitoring. So all the trainees that can be used whenever you are. So how are you using? Can you just tell us for the trainees' sake that how you using that IONM?
So for the robotic arm itself,
Yeah.
our neurophysiologist has sort of improvised on the attachment to the nerve monitor, which is directly can be connected to the robotic arm. And then we can use the robotic arm itself to identify the the nerve, and you
Yeah.
get the action potentials. The similar way, I think, even for I mean, the 24 hour, it can
Yeah.
be easily
Correct.
done. So it's not
Correct.
nothing difficult. It's just a minor improvisation that needs to be done,
Yeah.
and it will be very well used. And I think I do agree with what Siddharth said, but I'm not quite sure of Bethesda 3 and 4. For that, it can be very tricky when you offer hemotherapy all the time for Bethesda 3 and 4.
Yeah, that's why I've written here. When opted for
Yeah. So
surgery,
you
it's
you
like,
you need.
yeah, because you're keeping the patient in observation also half of the time.
Yeah, no,
More
not
than
only
that.
that, not
Yeah.
only that, and in a place like TMH where we are published, the incidence of malignancy in Bethesda 3 and 4 is close to 78%. So you can be more, less often you're going to be benign, more often you're going to be malignant. So you need to have the plan
Yeah.
as to what you're going to do. So you have to treat it like, you need to have the risk of malignancy rates for Bethesda 3 and 4 at your center. and then take a plan, make a plan accordingly, and don't
No,
just
but
go
if
with
the patient doesn't have any nodes and your plan is only hemi or a total
Maybe it's fine.
thyroidectomy,
That's what I'm saying.
then
So
that's, yeah,
you have to plan it like a malignant nodule only, depending on the
correct.
risk of malignancy for at your institute.
Yeah, correct.
You shouldn't stick to what is there in literature. That's the point I'm trying to make.
Yeah, that's very important. Institution-wise practice and what's your Bethesda rates based on that. So your planning should be ready beforehand. That what you're going to do in this
Yeah,
patient.
so
If it is a malignancy.
what generally I do is like in such kind of ambiguity, we request our pathologist to process the histopath faster
Yeah.
during the stay of the patient. So if that patient needs a completion, you can have within the same day and complete, I mean within the same stay period complete, then do the completion thyroidectomy, the same approach, because the fibrosis would not have set in, and the dissection would be easier, the flap raising and all. So this is what I perform.
Yeah. So
Sir,
with that, yeah, please. Anthony wants to say
Sir,
something.
one thing, sir, since this patient is a 43-year-old female patient, one thing we need to counsel the patient, as we have used transaxillary approach in this method, regarding the numbness of the chest region post-surgery, sir.
Yeah, that we always tell to patients because they have for
Yes, sir.
at least 4 to
That
8
is
weeks, they
one
have
thing
that numbness. Yes.
that should be taken into account for them, for female patients when we plan for this robotic surgery.
Yeah. So just to add up in the summary that we have already discussed about the benign grade 3, grade 4 Bethesda. Differentiated thyroid cancer also we can use robotic thyroidectomies in limited T1, T2 without any neck node or very minimal nodal disease in the central compartment. There should not be any major extra thyroidal extension. Generally has to be done in experienced high volume centers which are already doing it. And lateral neck dissection is difficult in transoral to address in that way, but can be done in transaxillary or very easy in retroauricular. So, but we'll come to neck dissection with respect to other malignancies also in the coming few slides. So, robotic neck
Can I
dissection.
add a point? Just
Yeah,
one
yeah,
point.
Abhishek, please.
See, in thyroid surgery, the choice of approach is also important, right? Because in Indian population, right, most of the thyroid, they are not feasible for a transoral, right? Robotic transoral approaches, they pose more difficult scenario for a surgeon as compared to a BABA or rabbit or a transaxillary approaches. Also, the retroauricular approach doesn't provide us a good option if we are thinking in terms of a total thyroidectomy, because in that case, we have to go for a bilateral incision, so the length of incision and possible complication rate increases. So the choice of approach is also very important.
Yeah.
Yeah, I kind of would like to, make a point and sort of disagree with what was mentioned by Dr. Abhishek. I think it all depends on the way you're trained. If you're trained in one approach more than the other, you would probably believe in that approach. I mean, even the pioneers of TOR or BABA, they're biased towards a single approach, which they have actually done over the years. But having said that, I think you need to, it's not that it's in Indian patient it is difficult. I think hardly there's any data. I think Siddharth will be having 100 cases and
Yeah, I
a few
was
other.
coming for that Siddharth only, that he has done the maximum transoral. So how difficult he finds in Indian population?
No, so before you go, I just complete my point. The thing
Yeah,
is that
please.
you have to identify the route that you're comfortable with, which you can do, and stick to that route and become an expert in that particular approach rather than venturing into all the approaches. Then we become jack of all trades and master of none. So we have to identify which is better in our setting, in our hands, the way you're trained, and stick to that.
Yeah, very well point said, Shiva. Yeah.
So,
Siddharth, yeah.
Totally agree with Shiva. So I kind of chose to go with transoral approach, and I then try to fit the patients that I can offer transoral. Okay, so for larger tumors, probably yes, very rightly pointed by Abhishek that this is not the right approach, but it has a feasibility of doing a total thyroidectomy at the same time when you are going through transoral. So if you are performing a total thyroidectomy for whatever reasons, probably transoral can be done with the size limitation of 5 to 6 centimeters of the thyroid or nodule size. So I have not gone beyond this transoral approach to venture into other options of transaxillary or BABA. So probably I'll try to fit whatever patients I can within these transoral approaches, and I will not extend it like say, okay, if I get larger tumors, I'll go transaxillary and or a BABA approach to do this remote access thyroid surgeries.
Yeah, it's better to stick to one that
Yes.
as we discussed.
Yes.
Okay, as you gain the more experience in that. Yeah.
Absolutely.
Yeah. So in interest of time, we'll just shift on to the neck dissection. Now that's robotic neck dissections are also being done, especially So any one of you performing robotic neck dissection and what route you are doing?
So I used to do retroauricular approach neck dissection that gives you
Yeah.
the best exposure in terms of almost as an open neck approach feel.
Correct.
However, the only reason I have not been continuing it is uh, the conversion of the space limitation constraints of the docking and the instrumentation and the post-operative scar hypertrophiedness and all. So I am not into more of robotic neck dissection for the reason that it doesn't add on much of value to the surgical outcomes.
Shiva or Anthony, anybody?
Yeah. So we've been doing quite a bit of retroauricular neck dissections, robotic assisted neck dissections.
Robotic assisted, yeah, correct.
Retroauricular approach,
Yeah.
and we have done quite a few cases, and we don't have a long term, but we would have somewhere close to 2 years results. Yes, keloid formation, hypertrophic scar is a concern. You need to choose your patients well, and in the initial phases, you will have the issues of the working space, the arm clashes, and all those issues will be there. But slowly you can navigate. The only advantage again is cosmetic, if at all, because you can have a hidden scar.
Yeah.
And disadvantage is the cost. And some people would say that I can do it, with laparoscopic instruments. Or there are various things, but there are N0 next is where we usually offer robotic assisted clinically and radiologically N0. Of course,
Yeah.
subsequently it will be N plus. That's a different thing. But we do offer this, and we are documenting our results, and hopefully we'll have something to put it across to all of you all to understand whether it needs to be done or not.
Yeah. So regarding we have ample
just like to
evidence.
add.
Yeah, Abhishek, you want to add something?
I have been doing infraclavicular approach. In fact, we have published our novel technique. It just got published this year. That is the bird approach. So we choose the bilateral infraclavicular approach. That the incision is between the clavicle and the areola, because the lower incision has got difficulty in approaching the instrument to the level 2 and level 1B. So we have modified the approach, and there has not been any surgical difficulty. On only comparison point is the surgical time, and we expect that with as we gain expertise in that, the surgical time will go down. In terms of nodal retrieval or in terms of surgical complications, it is comparable as to the open approach.
Okay, so are you taking the lymph nodes in the endo bags every time, whichever taking whichever
That is
level?
mandatory. Even for thyroid, even if it is benign, we make it a routine that it has to
No,
be
no, it
retrieved.
has to be retrieved by endo bag only. So there are various approaches. Most commonly is retroauricular, as we all are using, especially in the squamous cell carcinomas of head and neck. And the operative time is also not very significantly high, but there is no difference in the lymph node yield or the recurrences or the complication. So these are some patients intraoral. We did a segmental mandibulectomy. These patients, then fibula also. So scar, yeah, hypertrophic scar, especially in male patients. Sometimes it's a concern, but if you can very well hide it in the hairline, you see all these patients have undergone a free flap. So T1, T2, T3, N0, but generally it is N0 or otherwise only N1. When you gain enough experience, then we have done some few N1 also, but generally were you planning only to do N0 neck dissections, then robotic is in a very good access and approach for the outcome of these patients. Cosmetically also is very high. Shiva or Siddharth, you want to add something, or Anthony? Yeah.
Yeah, I think importantly it is just the cosmetic benefit that we are adding. We are not compromising oncologically.
Yeah,
That
right.
is safe. I mean, that is well documented. So those patients who are not desiring any cut on the neck, even if it is in the best of the hands, in the skin crease, good closure, good cosmesis that we explained. But yeah, so those patients probably would be the candidate for offering this options of robotic or maybe remote access neck dissection.
Yeah, especially the female patients with N0, where they can easily hide in the hairline
Absolutely,
for the
for those.
retroauricular.
So
Yeah.
what I used to limit is those patients having intraoral excisions, which does not require major reconstruction.
Yeah.
Those were the initial cases that I would choose for doing this kind of remote access neck dissection.
Okay. Anybody else want to make an opinion on that? Then otherwise we'll go for the last two slides and we'll just wind up in 2 minutes. Yeah. Shiva or Anthony, any point to add?
Yes, I think we have to be very careful in the patient selection
Yeah.
also, and I think you keep an eye on the the nodal yield,
Yeah.
especially in the initial days, because you don't want to be compromising on that, and
Correct.
keep a watch of it. And so far, that's what we have been doing, and monitoring the patient's satisfaction in terms of their scar satisfaction and things like that. So that it reassures you to carry on with what you're doing, and that needs to be monitored all along. So and then the rest of it will come in place.
Yeah. So coming on to the last two slides, then there is now a new wave coming up. We have already seen endoscopic nasopharyngectomies, now robotic assisted nasopharyngectomies also. So anybody of you having any experience on that have done robotic nasopharyngeal resections post recurrent tumors, post RT?
I have done laparoscopic, I mean endoscopic.
Endoscopic. No,
Yeah.
no, the robotic one. Yeah.
No, I don't have experience with robotic, only endoscopic. Yeah.
Yeah.
But
So
I've
there
watched
is.
I also don't have any experience.
Yeah, okay.
On quite a few occasions. It's pretty interesting.
Yeah, so there is a data coming up with small numbers only, but yes, it looks like very promising because again, the one is the vision it provides and the access. So what they have mentioned is Dr. Wei's group and everything, split palate approach where they split the palate, go from transoral route only, and in T1, T2 recurrent diseases, it should be more than 5 millimeter away from the carotid and not very lateral extension beyond the lateral pterygoid plate and no extension into the clival marrow. So these are the few cases where you can approach robotic also for recurrent nasopharyngeal tumors. So we are adopting robotic surgery faster than the evidence. No, there is ample evidence, especially as we discussed in TORS also it is coming up, and in robotic thyroidectomies it is already there and it is building on its previous evidence. Long-term outcomes are also coming up, which is in favor. So it can be provided as an as an option for the patients who want to go by minimal access routes. And functional outcomes, as we say, wherever the functional outcomes are also they are not outweighing the oncological equivalence. Both are this thing, but you have to choose your patient very well. Selection is, and generally you do your training or find a mentor where the high volume centers so that you gain enough experience before venturing into this. So definitive role in post-radiation salvage oropharyngeal tumors, T1, T2, DTC along with, but basically for the benign and the low-grade benign thyroid lesions for hemi or the total thyroidectomies that you can offer. Selected T1, T2, N0 as we discussed in TOS group, de novo oropharyngeal, supraglottic or sometimes in pyriform sinus or hypopharyngeal lesions also. Neck dissection in N0 status where intraoral primary surgery is planned initially where you're just doing intraoral primary without any reconstruction, but as you gain experience, you can do with reconstruction also. And post-radiation nasopharyngectomy, yeah, it is coming up as we discussed. And selected parapharyngeal space tumors also, this can be used where you can go transoral route. So one point for our trainees from all of the panelists, and then we'll wind up the session. Shiva, starting with you, please.
I think all the residents and fellows especially should understand that open approach is the standard, gold standard. You
Yeah.
need to be well trained in the open approaches, and as you gain experience and go further in your career, you could I will say should you could consider the minimally invasive approaches. Sometimes they are not minimally invasive; they're maximally invasive in terms of the
Yeah.
resections, but remote access surgery, if I could put it that way,
Yeah.
and get trained with with some of the leaders in this field before because sometimes when you start without actual training, that might act, and if you don't do well in a particular case, that might act as a negative feedback for you to proceed further. So to
Right.
get that right training, choose an approach and just be at it, be patient and learn that approach. And I think you could, be good at it. And another important thing is many of us are doing it in silos, various approaches. We need to get together, pool the data, and publish the Indian data, especially.
Yeah,
Would have
that's
some meaningful outcomes for the future. Thank you.
got it. Siddharth and
Yeah,
Anthony.
so
Yeah.
first of all, we need to understand that this robotic system is not devised for head and neck. So we are trying to fit our indication with the available instrumentation. Ours is more of a rigid and compromised, or maybe you can say a bounded area
Yes.
as compared to the GI, gynec, or maybe Euro people, where they have they have lot of availability of the space and other. So we need to definitely have more instruments designed for head and neck use. These are not actual ideal for our head and neck use, because we do need still more angulation or maybe flexibility in movements over and above the present 360-degree wrist options.
Yeah.
So yes, it is going to be the last subset probably among the head in the human body to have this remote access approach using robotics so definitely it has a definite role, a future, but a proper instrumentation is still required, or maybe instruments are required for a proper complete utilization of this robotic plan. But we can keep training ourselves so that we get that hand-eye coordination, our movements, so we should keep using and with the available resources.
Yeah. Anthony and Abhishek, one quick comment from your side, and then we'll wind up in respect of
So
time.
for residents, step-by-step approach is important. Simulation. First is simulation, invest time in training, and choose your patients carefully. Don't choose unindicated cases. Go from the low risk group, then gradually progress to the higher stage.
Okay.
That is my message.
Yeah. Anthony, please.
Sir, before the robotic instruments were very expensive, sir. Now with the patency coming down and the Indian robots coming in, now more and more robots will be available in other hospitals. So all residents who have recently completed and they are well versed with open surgery should find a good mentor, work with them, assist properly, and after developing the confidence only start operating alone. Initial few cases, it is better they can call someone senior, keep with them so that they gain that confidence, or even if anything goes wrong, they don't panic and they will have that backup. And this step-by-step approach will definitely help them, sir.
Yeah, so from my side, the only thing that this is going to stay, this is going to be there in the armamentarium of head and neck surgeons. But remember one thing, one size fits all is not the criteria. You have to choose your patients very selectively. Don't rush into operate everything by robotic approach. That is not a correct way to do it. Rest everything we have heard from our all panelists, very important points, pertinent points they have pointed out. And with that, I again thank you all of you for your attention. Thank you so much.
Thank you, Rakesh. Thank you, Poonam,
Thank you.
for this honor.
Thank you, sir. Thank you, ma'am.
I think it was quite a comprehensive panel discussion on robotic surgery, including all the aspects, even the sites of head and neck for discussion. I would like to thank the panelists, Dr. Shiva, Dr. Siddharth, and Abhishek and Anthony for their insightful comments and all the discussions. And with this, we reach the end of this TMC Postgraduate Teaching Webinar 2026. And I would like to conclude it by saying thank you to all the people involved. I would like to first thank our director, Dr. Pankaj Chaturvedi sir, for providing all the academic, scientific, and logistic support. I would like to thank Dr. Sudhir Nair sir, who is the head of the surgical oncology at ATREC, for all his academic support and other help. I would like to thank our IT team, especially Prem and Rohit, for the smooth conduct of the program. I would like to thank all the experts yesterday and today who actually spent so much of time in making these PPTs and bringing forth so many aspects through their experience and knowledge for the sake of students and making it as a successful program. I would like to thank all my students who were involved in this program. A special mention to Shivaji, Shobhan, Sashwat, and Shafi. And I'm sorry if I can't take name of each and everyone. And I would like to thank the wonderful delegates who were involved in the entire session today as well as yesterday. Throughout with a lot of discussions on the chat box. And with this, I conclude this conference of this year and look forward to meet you all next year. Till then, goodbye and take care. Thank you so much.